Okay, it is 9:04 a.m. on July 29th, 2021, and we are once again on a virtual Public Employees Benefits Program Board meeting. So welcome everybody. I'm sorry we are not doing this in person like we planned. And with that, I'll ask staff to call the roll.
Laura Freed.
Here.
Linda Fox is excused today. Betsy Aiello.
Here.
April Caron.
Here.
Michelle Kelly.
Here.
Jennifer Krupp.
Here.
Tim Lindley.
Present.
And Tom Verducci.
Here.
Thank you. We have a quorum.
Okay, thank you. If you could mute yourself when you're not talking, that would be helpful. And I wanted to note a little bit of an adjustment to the agenda, board members. I think after public comment, what we'll do is take agenda item 6 on the Northwest Prescription Drug Consortium, because we have a couple of panelists who have other meetings they need to attend. So we'll do that, and then we'll go back to the agenda and pick up on agenda item 3 and then go in order. So with that, I will open up the first public comment period. Broadcast, take it away.
Thank you, Chair Freed. To provide public comment, please press raise hand in your Zoom window or *9 on your telephone to take your place in the queue. Mr. Miller, please press *6 to unmute.
There, can you hear me now?
Thank you, Mr. Miller. Yes, please proceed. You will have 3 minutes.
Okay, I wanted to talk about the healthcare benefits and a few things in it, aside from the perpetual shortage of money that I know you're dealing with the state budget and trying to allocate our healthcare costs as well as possible. Some things you have are really causing problems, I think, for healthcare. One is that using HealthScope to kind of as an intermediary between that and the insurance company at Aetna. I think it's causing some problems because it kind of incentivizes denying care. For instance, in the report you're getting today, it talks about the number of claims submitted and then number of claims for, say, pieces of durable medical equipment that they were able to deny. It never has a spot on it for how many of those were then actually given to people on appeal. The other thing is that it's a system that a lot of the providers don't understand. They keep asking, are you insured by Aetna? Are you insured by HealthScope? We don't take HealthScope. I've even had HealthScope on a 3-way call with the providers to try and explain what's going on. And finally, it causes some real problems for me. I had to have a BiPAP machine replaced because of the Philips recall of all the BiPAP machines that are used. Now, granted, my experience was complicated by the recall, but the problem is the provider refused to submit a claim because they said your insurance won't cover it because it's been less than 5 years. I was talking to HealthScope the whole time and they're saying, no, we'll approve it, but the provider still wouldn't budge and submit the claim. But the problem is HealthScope has no sway over them because they're a provider to Aetna and we have no way as members of contacting Aetna. So this extra layer is really causing some problems. Finally, this relates to what's coming up on your agenda with the pharmacy benefits. This mandatory 90-day thing has got to go. It wastes money when dosages change, which can often be frequent if it's regarded as a continuing medicine. There's no provision for how many times you might need 30-day prescriptions to find the right dose. They only give you 2. And a lot of psychiatric medications, if you're seeing your psychiatric provider more than once every 90 days, they don't, for safety reasons, they don't want to prescribe for more than the time between your appointments. So you keep your appointments, which can be a problem in a mental health setting. And there's no provision for when it's unsafe to prescribe for longer periods. And they're spending a lot of marketing money constantly trying to force you to get into mail order. And maybe if they spent less money on marketing and more money on paying claims, they wouldn't have to force people into a 90-day program. And those are my comments that I have for today's meeting.
Caller with the last three digits, 499. Please state and spell your name for the record. You will have 3 minutes and may begin.
This is Carter Bundy with AFSCME, CARTERBUNDY. I first of all really just want to thank the board. We have looked at the agenda, and item number 8, which includes possibly putting in for ARP funds as well as potentially other monies to restore the cuts that have happened to state employees' healthcare and retirees' healthcare is incredibly important. We encourage you to support that. And I want to make it clear, AFSCME will be a willing and active partner to try to get the resources that PEB needs in order to restore these cuts. You've been hearing us ask for this for a year now, and we are really grateful that you are addressing this on today's agenda. And again, please reach out to us at any time for any help we can give, and we'll certainly be active with IFC. And we want to thank you for considering agenda item number 8. Thank you.
Caller with the last three digits, 111. Please press *6 to unmute. And thank you, caller. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good morning. My name is Janelle Woodward, JANELLWOODWARD. Thank you, Chairwoman Freed and board members for hearing our public comments. I'm a state employee and a member of AFSCME Local 4041. Our union AFSCME fought very hard for the American Rescue Plan to include aid to state and local governments. This is very important for our collective recovery from the pandemic, which of course we are still in the middle of. According to the guidance provided by federal government, ARP funds are intended to be used to restore cuts caused by the pandemic. This includes the cuts that had the PEB budget had to endure in response to the economic impact of the pandemic to the state budget. I have recently experienced myself the results of the huge cuts in the transfer of costs from health plans to state employees. We're only 1 month into this new plan, and it has already had detrimental effects to my personal well-being as well as my financial situation. Coverage changes are not good, and the out-of-pocket is significant after taking 6 months of pay cuts with furlough days. I've worked throughout the pandemic along with my coworkers and most of the other state workers to provide much-needed public services to the communities of Nevada. We do this because it's the right thing to do. We urge the PEB board to also do the right thing and make the request to restore the cuts to our health care with ARP funding. This is important to all state employees, and again, is frankly the right thing to do. Please consider prioritizing state employees and making the request for those ARP funds. Thank you very much.
Caller with the last three digits, 832. Please slowly state and spell your name for the record. You will have 3 minutes and may begin.
Thank you and good morning. My name for the record is Terry Laird, spelled TERRILAIRD, and I'm the Executive Director for the Retired Public Employees of Nevada. We are a nonprofit, nonpartisan organization formed in 1976 to protect pensions and benefits earned by all public employees in Nevada. We have nearly 8,000 dues-paying members, mostly retirees, but we do also have nearly 1,000 members who are still active and working for state and local governments. We are concerned with action taken by the most recent legislature at the 81st session ending June 1 that led to the elimination of long-term disability and mandated budget cuts that have led to higher out-of-pocket costs for actives, a reduction in life insurance for actives and retirees as well. We also must note the news that reserves or profits, as our legislative advocate Marlene Lockhart refers to them, are still within $35 to $37 million. Plus, we, like most of our fellow public employee advocates, do hope that PEB is able to benefit from some of the nearly $3 billion in federal reserve funds that the state has in its coffers now, along with American Rescue Plan funds that will be available for a number of years going forward. I'd also like to point out what Nevada Senator Pete Goicoechea said during a PEB budget hearing at the recent legislative session. Senator Goicoechea testified at that hearing about cuts made during this legislative session that will ultimately impact state recruitment and retention, something we got used to hearing from Assemblywoman Maggie Carlton, who termed out after 26 years of legislative service. Hopefully, as we look forward to new faces at the next legislative session in 2023, that message will still ring loud and clear. Without a viable state workforce who can earn a decent living and sustain good health care with good benefits through PEB, the state will be facing dire straits in the not too distant future. Thank you.
Thank you. Priscilla Mahoney, please slowly state and spell your name for the record. You will have 3 minutes and may begin.
Thank you. This is Priscilla Maloney, Priscilla-Maloney, representing the AFSCME retiree chapter this morning. I just want to echo everything that's been said by all the advocates, especially, of course, Carter Bundy, representing the actives today, and our member, Ms. Woodard, and thank the board for all their difficult work in the past and what's ahead in the times to come as we try and pivot and navigate through this changing environment. And as to agenda item 8, we appreciate the conversation. We understand that this is just the beginning conversation on these potential options that will be submitted, I believe, to the treasurer's office, though I'm sure staff can correct me if I'm wrong on that. But thank you again for all your efforts. And then just for the sake of LCD staff, I'm going to log out of Zoom now and then switch over to the regular streaming LCB run feed so that I can not jam up the phone lines, as it were. Thank you.
Caller with the last 3 digits, 832. Please press *6 to unmute. Okay, that caller has dropped off. As a reminder, we are currently on public comment. If you have joined the call and would like to speak on public comment, please press raise hand, in your Zoom window, or *9 on your phone to take your place in the queue. Caller with the last 3 digits, 003. Please slowly state and spell your name for the record. You have 3 minutes and may begin. Caller with the last 3 digits, 003. You are unmuted. You may begin your public comment now. Assuming caller with the last 3 digits of 003 did not intend to unmute. At this time, Chair, there are no additional callers or participants wishing to provide public comment at this time.
Okay. Thank you very much. I appreciate the assistance. And reminder, if you didn't get to get in the queue for public comment, we have a second period of public comment at the end of the meeting. So with that, I will switch up the agenda order as I mentioned before, and we will go to agenda item 6, which is presentation and possible action on the Northwest Prescription Drug Consortium. And so I will turn it over to the executive officer.
Good morning, and for the record, Laura Rich, Executive Officer. As Chair Freed mentioned, this is a report on the Northwest Prescription Drug Consortium. So a little bit of background, during the last several legislative sessions, the legislature has passed various legislation that gives state agencies some authority to leverage their buying power by joining purchasing coalitions. So for example, NRS 277.110 authorizes public agencies to exercise any power jointly with a public agency of any other state. And then NRS 333.435 specifically allows a state agency to join with governmental agencies of other states for the collective or collaborative purchasing of specifically for prescription drugs. So Senate Bill 396 that was presented this last session also went on to expand this authority and include not just government agencies or public sector agencies, but also private entities as well. So PEB's pharmacy benefit manager contract with Express Scripts is due to expire on June 30th of 2022. The board has already approved an RFP, so solicitation for that contract, to replace that contract beginning on July 1st of 2022. So in addition to planning and preparation for this RFP release, PEB has also explored and analyzed an option of joining an established prescription drug purchasing group through the Northwest Prescription Drug Consortium. They will be here. They will be presenting after my report here. So the board will have the opportunity to ask questions and to get a lot more information. But I just wanted to provide kind of a high level report on what it is that PEB has done and how we've gotten to this point. So the Northwest Prescription Drug Consortium is a group that was created as part of an interstate agreement between Oregon and Washington as a means to leverage purchasing power between the two states. So the consortium was formed to allow Oregon and Washington state agencies, other local governments, businesses, and labor organizations to pool their purchasing power to get better pricing on prescription drugs. The goal here is to achieve full transparency using fixed costs and using 100% pass-through model. This ensures that participating programs pay exactly what a pharmacy is paying for a medication. We don't have that current contract, and I'll explain that in a minute. Our contract through ESI is it doesn't follow that model. This pricing model is beginning to be offered among traditional PBMs, but it is not what we have today through our ESI contract. Instead, PEB participates in what is the more common pricing model today, which is where the payer PEB is billed more than pharmacists. Sorry, I got all tangled up here. So instead, we participate in the more common pricing model, which is where the payer, which is PEB, is billed more than pharmacies, and then the PBM keeps the difference. So this is referred to as spread. Although PEB receives aggregate data, this type of model lacks transparency. So we don't get the specific drug costs, we don't get the specific rebates, things like that, that is provided in a more transparent model. So from a member perspective, the consortium functions very similar to a traditional PBM model by offering the typical retail and specialty pharmacy access and all the customer service tools and the amenities that are offered by PBMs today. So we did an extensive analysis. Aon helped us through this process where we used actual claims data and determined that, and I want to emphasize this from a cost perspective, that the consortium in comparison to what we have today with ESI is significantly more cost effective. I'm going to say that I'm not going to make the number public, because if we do go out to RFP, it is not in our best interest to say how significantly more cost effective this is. So I'm just going to say that it is significantly more cost effective. However, it's extremely important to note that although PEB has completed a general comparison of non-cost related factors. So we've asked questions regarding member tools, pharmacy network, cost containment programs, formulary options, everything. We've asked a lot of questions. We've had staff ask a lot of questions to the consortium staff and their vendors. The comparison has not undergone the scrutiny that would have been required in a typical RFP evaluation. So we've asked questions, but it is not in writing. It is not, there's no contractual agreement set in place today. So it appears, based on the discussions that we've had with the consortium staff and their vendors, that the consortium could conform to PEB requirements quite easily, and they would be able to replace our PBM quite easily pretty seamlessly. But those in-depth contract discussions could uncover unforeseen challenges which have not yet come to light. So PEB has several options here on how to proceed and ultimately contract. There's 3 options that we are presenting. So the first one is that we do recognize that existing statute does allow us to join the consortium. We don't have to go through a formal RFP process. We can choose to join the consortium without doing a formal solicitation. So that's option number 1. Option number 2 is that we can opt to continue normal course of action and release a formal solicitation for a PBM. And we can ask the consortium to bid on that through, to submit a formal proposal, and that they would be evaluated just like any other entity would submitting a proposal. That's option 2. And then the last option is kind of a little bit of, it is definitely something that I had to talk with purchasing quite extensively on, and I think what we came to an agreement here on how the best way to do it is, and we do have someone from purchasing, Gideon Davis, here to answer questions regarding this, but we can release a formal solicitation for a PBM. So once a winning bidder is selected, through an evaluation committee and through a normal solicitation process, the board, this can be brought to the board along with a preliminary contract or negotiated contract with the consortium. And those 2 options can be weighed and they can be considered. And then at that point, the board has the ultimate decision as to whether or not it wants to award it to the winning bidder, or if they would like to award it to the consortium. And that this gives the opportunity for the board to have that final decision and weigh the 2 options. The staff recommendation here is essentially either option 2 or 3, because option 1 introduces some risk. We can get, as I said, halfway down into the negotiation phase of negotiating a contract, and we could find ourselves in a situation where we potentially find a deal breaker. And at that point, it's too late to release an RFP. It is too late we're now up against a time clock, and we are unable to develop and release an RFP in time for implementation for July 1st of 2022. So because of that, staff is recommending option 2 or 3. It just provides a safety net to ensure that we have some sort of plan B in place, and that we can move forward with a specific and detailed contract negotiation moving forward. So with that, I just want to say that we do have, I asked a lot of subject matter experts to attend today. We do have Dr. Beth Slamowitz. She is the DHHS Senior Policy Advisor on Pharmacy. She's been working with the consortium and has she worked with the consortium on the Senate Bill 396 and has a lot of information and knowledge. We also have Amy Daly on the line, who is a representative from our current PBM, Express Scripts. As I said, Gideon Davis from purchasing is also on as well to answer any purchasing related questions. And I'm going to pass it off to Donna Sullivan, who is the Chief Pharmacy Officer from the Washington Healthcare Authority, who's going to present a piece on the Northwest Consortium. So Donna, if you want to take it over.
Sure, thank you. So I'm not sure who's putting up the slides, but we did have a slide deck that we were going to present.
I can put them up.
Okay, that'd be great. Thank you, Lita.
Hang on just a second.
And so while Lita is putting those up, I don't want to take up too much more time. With us today from the consortium, thank you all for inviting us to give this presentation. And today with us from the Northwest Consortium from the State Steering Committee, myself, Donna Sullivan, I am the Chief Pharmacy Officer for the Washington State Healthcare Authority. I manage our Medicaid program as well as our Public Employees Program and our School Employees Program, Pharmacy Benefits. With us, we have Trevor Douglas, who is the director of the Oregon Prescription Drug Program and Pharmacy Purchasing within the state of Oregon. I also have William Hayes, who is the director of pharmacy for the Washington Department of Corrections. I have Lita Vasquez, who is the Northwest Consortium Operations Manager for Washington State, and also Bill Beck, who is the director of the Oregon State Hospital. So collectively, we make up the steering committee. From Moda Health, who is our consortium administrator, I have Robert Judge, who is the director of pharmacy services from Moda Health. Also have Pam Demmer, the manager of innovation and strategic accounts. And then also joining us is Shonda Wargren, who is the senior vice president of pharmacy at Moda. So next slide, Lita. So today we're going to go through the Northwest Prescription Drug Consortium overview. We'll look at the general responsibilities of pharmacy benefit managers. We'll do a more in-depth analysis of what the Northwest Consortium PBM services are, and then look at what is in it for a public sector member state by joining the consortium. And then we do have some time set aside for questions and answers. So we ask that you save your questions for after the presentation. Next slide, please, Lita. So I'm going to kind of tell you a little story. The Northwest Consortium in Washington State, it started back in 2001 when our governor directed the state agencies that purchase prescription drugs to create a work group and actually look together for ways to consolidate purchasing and use our combined purchasing power to leverage the ability to negotiate better price for prescription drugs. So those agencies include the Department of Corrections, Labor and Industries, the Veterans Administration, the public employees, our Medicaid program, Department of Health, state hospitals and even the university hospitals. So we combined this work group, and we really dove into the different ways that the different agencies purchase drugs. Some purchase drugs directly, and others, more like the Public Employees Program, were reimbursing pharmacies for drugs dispensed to our members. So since 2001, we've been working together across the state. And with that came a report that went to the governor and the legislature. And out of that, legislation was passed that instructed the healthcare authority in Washington to create a purchasing consortium, and which is what we started doing. And we established it officially in 2003. And over time, as we were working, listening to other states, we found out that the state of Oregon was also going down a very similar parallel path. And through that, Oregon and Washington collectively decided that we were going to work together. And we started with a pharmacy benefit management contract and a discount card. And we released an RFP in 2006, and MOTA was the selected vendor at the time. We've reprocured the contract several times, and MOTA has been selected again and again. So the consortium itself is an interstate agreement between our two states of Oregon and Washington. It is it's managed by states, it's for states. We have a great relationship with our vendor. It's more of a partnership rather than a vendor. So there's a lot of flexibility to meet all of our needs. It's intended really to meet, the focus really is on public entities and what they need, and where, stewardship of taxpayer dollars is our highest priority, which is, why we have the transparency and the pass-through setup that we have. It's overseen, again, by all those state officials. Combined, we have over 100 years experience in pharmacy supply chain and pharmacy benefit management and contracting. And it's available to any state entity or any public entity that wants to join the consortium is able to join. And also private entities are able to join if they do. And we have multiple participating programs, many state agencies in Washington and Oregon, and then several private agencies within both states too are also participating in the consortium. And with that, I'm going to turn it over to Trevor Douglas to give you some more details about the consortium itself.
Thank you, Donna. I really appreciate you covering and introducing the consortium. I want to briefly touch on the consortium's procurement standards and processes. Since 2006, we have abided by Oregon procurement law and upheld those standards in procurement. And routinely, we've gone out to market, as Donna alluded to earlier, to test the market, make sure that we have the best possible contractor available to serve our needs. Also, just recently, the recent RFP was, we were granted the ability to issue a 10-year renewable, up to a 10-year renewable contract through that RFP process, which just speaks to the level of comfort that our Department of Administrative Services in Oregon has with our RFP process, our evaluation of that RFP response, and also the contracting negotiations. And a little bit more on that, our process includes a robust team. In addition to the steering committee that Donna touched on, we also had oversight from both states' procurement offices, with a procurement officer participating in all of our discussions, and from the beginning up through till the end. And we also had involvement from the Department of Justice in Oregon and the Office of the Attorney General in Washington State, all of whom contributed greatly to our RFP process, the evaluation process, and ultimately the contract negotiations. Needless to say, it's a robust process that has demonstrated its effectiveness. I also just wanted to just say that, the statute in both states actually encourages us to work together and provides us the statutory authority, much like Laura Rich outlined is the case for Nevada. And with that, I'm going to talk a little bit later about membership in the consortium. So I'm going to save that up and instead turn it over to William Hayes to talk a little bit more about the consortium's programs. William?
Good morning. The consortium provides an array of services, as you can see on this slide. The most important for the topic today is the pharmacy benefit management services, as we have mentioned, with true transparency. But we also want to highlight that we provide a discount card program that is available for prescription drug purchases by all residents of participating states. Important to my program at the Department of Corrections, we provide a group purchasing service via an existing intergovernmental relationship with MCAP Infuse, which is a Minnesota state entity and program offered by that state. The consortium is also currently developing a comprehensive fee-for-service Medicaid solution with the same 4 states by states premise and goal of delivering additional best-in-class product services. Next slide. The Consortium Steering Committee, which is represented today, provides oversight and governance of the programs further represented as the honeycomb in the center of the diagram presented here. The gray ovals describe the key functions in operation of our programs, which highlight our flexibility, commitment to oversight, innovation, and predictable cost. Our true pass-through pricing, fixed administrative fee, and annual market checks are clear markers of a best-in-class PBM offering for the public sector marketplace. This information is self-explanatory and demonstrates the commitment of our contractor and our state staff to steadily grow participation within the consortium. It also demonstrates our commitment to existing clients and positions us well to serve additional states. Robert Judge will now provide an overview of the responsibilities of a PBM.
Thank you, William. So, before we get into the specific details about, am I displaying myself yet? Before we get into specific details about the Northwest Prescription Drug Consortium, I thought it might be helpful to really overview what the pharmacy benefit managers are and what they do. So I'm going to cover this in the next couple of slides for you. So, Lee, if you advance, okay, great. So, as William described in his slides, the consortium really offers kind of a range of programs that cover all manner of services that payers of prescription drugs require. This includes really the functions of PBMs, or pharmacy benefit managers. PBMs are companies that manage prescription drug benefits on behalf of payers, like health insurers or self-insured, and employer groups like PEB. The primary responsibility of PBMs is for, they cover a range of services, developing and maintaining drug lists, which are known as formularies or preferred drug lists. They're responsible for contracting on pricing with pharmacies, so you can get your drugs dispensed at pharmacies at a negotiated price. They negotiate with manufacturers for drug rebates, and most fundamentally, they process and pay for prescription drug claims. In their simplest form, PBMs operate as middlemen between payers like PEB and the networks of pharmacies they manage, and the pharmaceutical manufacturers who provide drug rebates on PEB's pharmacy benefit program. They're an important player in the healthcare supply chain since they help manage the cost of drugs from manufacturers and ensure the safety and appropriate utilization of medications in a group's pharmacy benefit. So while they're necessary and they play an important role in healthcare today, historically they've operated mostly in the dark. And that's kind of alluded to in Laura's discussion of spread pricing as an example. There's not a lot of visibility into the way they make money on the services they provide, or more importantly, how much money they make from payers like PEB when they provide their services. So the lack of transparency about kind of their financial incentives and their business practices has raised a lot of unanswered questions about PBMs in general and how they operate. And many state legislatures are calling for or enacting increased legislation to regulate the PBM industry. So that's it. If you jump to the next slide. So that's just kind of an overview of kind of background of PBMs. So in the next couple slides, Trevor and I are going to tag team what the consortium's PBM program offering is and the oversight and governance that is used to ensure an open and transparent process. The consortium in its kind of PBM model provides full service sets of services that Laura kind of alluded to in her opening remarks. It provides pretty comprehensive prescription drug management and rebate administration services, which are fundamental in a PBM program, but they depart from how PBMs operate today, in that they're open, predictable, transparent, fully auditable are the kind of the tenets that hold up the PBM program. And because, as Trevor referenced, it was built by states for states, it includes governance and oversight to ensure taxpayers' dollars are used efficiently. But it's also constructed to overcome the lack of visibility into PBM program operations that I highlighted as an issue in the PBM industry overview in general. As a comprehensive service, the Northwest Consortium program includes all the elements required to effectively administer a pharmacy benefit program. These include the elements outlined on this slide, as well as many additional and optional ones because of the kind of the flexibility of what the program allows. Taken together, we believe the Northwest Prescription Drug Program, the Pharmacy Benefit Management Program, is an attractive alternative to the traditional PBM models that are out there, because it's transformative in how it conducts its business and embraces the openness and transparency required in the market today, which from your perspective, not only gives you insight into how taxpayer money is being spent for prescription drug programs, but gives you better insight into oversight for that PBM service that you're providing to members. So to deliver these services, the consortium is contracted with Moda Health Plan that Donna alluded to. Moda is a provider of dental, medical, pharmacy insurance, as well as administrative services, and we're located in Portland, Oregon. But we have operations in the Pacific Northwest and beyond. We've been in the PBM business since 1998. We've actually been managing prescription drug claims since 1985. But we administered the PBM services for the consortium since 2007, following the RFP that Donna spoke to. So the consortium's PBM services are delivered by Moda to your members by our teams of clinicians, pharmacy benefit management specialists, as well as customer service support personnel. These services are delivered in that kind of rectangular platform in partnership with Navitus Health Solutions. Navitus is a PBM that really fundamentally focuses on the kind of the public sector marketplace, and they're headquartered in the Midwest. They prefer the services that they perform are really under our oversight and direction. So they really provide the kind of the platform under which PBM services are delivered. Together, this platform gives you a pretty flexible and responsive, customizable pharmacy benefit program for groups to join the consortium. And we have the flexibility to kind of customize and tailor those programs to meet the specific and unique needs of the participating programs. So that's my kind of overview of kind of Moda's role in the PBM industry, what the PBM industry does. I'm going to turn it back to Trevor, who's going to continue to overview the consortium's PBM program.
Thank you, Robert, very much. Next, let's just shift a little bit, but not too far, and talk a little bit about the foundational operating principles that we operate under that benefit everybody that participates in the consortium. First of all, over time, we have adapted our contracting and program offerings to ensure that we lead the nation with respect to 100% pass-through pricing, i.e. no spread, 100% pass-through of rebates. And we also have ensured that we have full audit rights to every contractual relationship that we have. And I think perhaps the most important part of our oversight kind of centers around our annual market check. Together, the Consortium Steering Committee, Moda Health, and a third-party contractor conduct a market check and benchmarking exercise to ensure that our administrative fees and our price guarantees are competitive within the marketplace. And I think what I need to underscore here is the important key, how we make that meaningful. We have in our contract a trigger that defines when that market check and benchmarking shows a better position in the marketplace. Our contract allows us to open immediately negotiations with our contractor and subcontractors to ensure that we remain competitive. And so I think that's really, really important and demonstrates our proactivity to protect not just the consortium, but also all of the participants within the consortium. And the other thing that Robert's already touched on is this isn't a monolithic solution. This is a solution that is customizable and serves the need of each individual entity that chooses to participate with us. Next slide, please. Thank you. And, I think it's important to just spend a little bit of time to talk about what Laura Rich touched on and what we've already spoken about as it relates to spread. The value of what the consortium has in its pass-through pricing, contracted structure and oversight is demonstrated here. If we just look at the last 5 years, we can see, if you look at the chart, just to help you understand it, the light blue line or the teal line is what the contract's established guaranteed price would have been. And if you look at the dark blue line, that is the cost that the plan actually, or the participating programs actually paid. And you'll see that that's less. And so this just demonstrates to you that we've consistently over time performed better than what our guarantees were. And that was passed immediately on to the payers. And that translates to an additional savings of over $135 million over that 5-year period. All right, let's move on now, and let's loop back to the conversation that I wanted to take us to now, which is membership, and how can a state join the consortium? So a public sector entity can elect to participate or join as a full partner or member state with the consortium. As a state entity, we would welcome the Nevada Public Employees Benefits Programs to explore the opportunity of membership. What does that mean, and what does that translate to? Well, it would allow Nevada's members, representative to participate in all of our consortium governance and oversight reviews. These things include things like I described, the market check and benchmarking exercise, any of the audits and the reporting that we do, and any of the annual meetings and semi-annual meetings that we conduct with our contractor and subcontractors. We also would have a place for you to have voting rights on the Consortium Advisory Council, be able to attend all of the steering committee meetings. And also, as we push forward, we do hope to have events and meetings beyond Zoom that would be consortium sponsored, and you would have also special access and designation for those. And then finally, I think it's just, also helpful to kind of know and measure how you're doing with everybody else in the consortium. And so there would be also some de-identified reporting to help see how we perform when we're speaking about and comparing how well the program you're administering is doing against all of the others in the consortium. So in summary, I hope that we've answered some of your questions, but I'm sure we've also sparked some new ones. But before we get to those questions, I just want to make sure that you understand that the Consortium Steering Committee that's represented here today, Moda Health, and even Navitus are poised to pursue expansion within Oregon and Washington with the current efforts that are underway and the planned efforts. And we're also poised to do the very best that we can for delivering our best-in-class services to Nevadans. And furthermore, we aren't a stagnant group. We like to innovate. We like to hear about chances to improve our offerings and introduce new programs, as evidenced by our soon-to-be launched fee-for-service Medicaid solution. But we're a game to be evaluating and work towards any innovations that improve the pharmaceutical supply chain fulfillment, distribution, and even manufacturing options that align with our fundamental operating principles. So in closing, I just want to thank you very much for the opportunity and extend a warm welcome to Nevada to join our already successful alliance between Oregon and Washington, and to also benefit from that alliance that we've appreciated for the past 15 years. We're open now for any of your questions or anything further that you'd like to ask us about.
Laura Freed. Thank you very much, ladies and gentlemen, for that presentation. I will open it up to the board members for questions of the panelists or questions of the executive officer.
Yes, Tom Verducci for the record. I'd like to ask a question as far as, can any group join the program as far as the underwriting process? Is there any capacity issues in terms of minimum contracts, maximum contracts, and what would be the process for undertaking a new group? And if you could address the capacity issues, that would be very helpful. And thank you for being here today as well.
Hi, this is Donna Sullivan. So Robert, I'm probably going to pass this off to you as far as the capacity. For self-insured programs, there really is, I believe, no capacity limits. If you're fully insured, that is an underwriting question for MODA to respond to. So Robert, are you able to answer that question, or do we need to?
No, I think we can. I think I can. So there's the consortium program is primarily kind of a service that's available to folks who procure and use pharmacy benefit services as a administrative services offering. So it tends to, at least from a participating program perspective, most of the participants are external, have medical coverage under a medical provider, and pharmacy services under the consortium arrangement. But we do have some of our participating programs who operate the consortium inside a medical benefit. That medical benefit is really underwritten by MODA, so we provide the medical insurance as well as the consortium's pharmacy benefit program. And so we have that vehicle. Of course, it's only available in states where MODA's medical programs are licensed and insured, is set up. So and then there are kind of minimum group sizes for kind of underwriting that. But I think the question you're getting at is in terms of how is pricing determined and kind of what is it mean by each participating group. The one of the advantages of the consortium, I think one of the principal advantages of what the consortium delivers is the fact that you've got a pooling of disparate purchasers out there, and you're pooling their aggregated purchase volumes, and that really gives us opportunities for leverage in the marketplace. not only in how we build pharmacy chains and work with our the pharmacy partners, but also with manufacturers around kind of the rebates. And those rebates are passed through at 100% of anything that's collected from the manufacturer that we collect is passed through 100% to the participating programs. So that aggregation allows us to establish kind of significantly discounted pharmacy benefits and significantly sized rebates that each participating program gets to benefit from, regardless of size. So, the point is, if you're a 1,000 life group, you're benefiting from really the effective aggregation of all the consortium's lives that are used to negotiate both network discounts and manufacturer rebates. Does that answer your question?
Yes, it does. So a 1,000 life group would then get the same pricing structure and benefits as the larger, let's say, state groups. Is it the same pricing across the board, or is there any additional benefits and cost savings for larger groups, or is the pricing the same for all participating members?
And this is Don. I'm going to jump in here. So Tom, the pricing is the same for the different groups, regardless of size. I think where there is differences based on the size is in some of the reporting and in some of the guarantees where we consolidate the small groups together when we're looking at the reimbursement guarantee. We consolidate the small groups together when we're looking at, did you meet performance targets as far as, speed to answer a telephone, customer service, the turnaround times on prior authorization. So some of those performance guarantees that are within the contract. But as far as the reimbursement to the pharmacy, the administrative fees, all of that is the same regardless of group size.
Okay, very, very good. And thank you for addressing the questions there. So as the board meets every other month thereabouts, would we have representatives that would be available to either attend in person or on Zoom? We had specific questions during board meetings.
I think we could commit to having a consortium steering committee member at your board meetings, at least on Zoom. Whether it's in person, it would be a matter of, who's going to pay for travel probably, and whether or not as a state employees, if we're with the pandemic still going on, if we're able to travel. So yes, we could participate at least via Zoom.
And if I could just add on top of that, Donna, as kind of the administrator for the consortium program, MODA would be kind of the primary contact for all benefit administrative services, and could be available at your board meetings as well.
Okay, thank you. And just a couple other questions here. So in terms of the procurement process, would this be a standard contract, or would there be additional benefits that we could gain and negotiate through an RFP process?
Is that a question for the consortium or a question for your procurement team in Nevada?
I think it's actually for both. What I'm struggling with here is decisions, that we're going to make here today in terms of going through RFP processes. I'm going to actually defer that question to our executive officer as we conclude the presentation here.
Mr. Verducci, this is Chair Freed. I think I'm going to ask a more pointed question, which may be tangential to the one you posed, and I suspect this is going to be one for Mr. Davis of the Purchasing Division. Would this be a joinder contract? And if yes, is this something that has been evaluated by the Purchasing Division to meet NRS and NAC 333?
So this is Gideon Davis from State Purchasing for the record. Yes, the Purchasing Division has looked at this consortium and the legality of it. Similar to the Western States Contracting Alliance, of which Washington and Utah and Nevada were all founding members of back in 1993, this type of cooperative contract is encouraged by our state laws, just like it is in Washington and Utah. We actually have a more recent law, NRS 333-475, that was enacted by the legislature in 2019, that specifically allows us to enter into contracts pursuant to a solicitation for a bid or proposal by other government entities. That, in addition to the two laws that Laura already mentioned, between the three of those, we absolutely have the authority to join this consortium. And generally, as demonstrated by our participation in WISCA and NASPO and other cooperatives, the Purchasing Division of Nevada generally feels that it is better for us when we do things cooperatively and collectively with our other states, because our needs are similar and a rising tide lifts all boats.
Tom, I also, this is Donna Sullivan again for the record. I wanted to jump in. So I've been with the consortium since the very beginning, and I've been managing our public employees self-funded program since 1999. And I can tell you that the contract allows for custom projects or programs. So what we're currently doing now, we've just reprocured the contract, so we're renegotiating the contract with our state employees program. And if there's terms in the contract that don't quite meet your needs, you're able to negotiate different terms with MOTA, and you know, that's on a mutually agreed upon between you and MOTA. And there's a section in the contract that'll say, paragraph whatever X, Y, Z is replaced with this language here or these terms. So there is the ability to negotiate different terms of, like, if what we have done doesn't meet your needs, you can, tweak those a little bit and make it so that it's custom to meet the needs of your particular program.
This is Betsy Aiello. I have a question, if now's a good time to go ahead and ask.
Absolutely, go ahead.
So from my understanding, this has been Washington and Oregon up to this point, and it looks like having felt that the program has been successful, and with more lives, maybe better negotiation can occur even more, the program is looking to leap to other states or other entities. So if the board was to look at option 2 and releasing an RFP, it says, and the consortium will be considered if a proposal is submitted. Is the consortium thinking about starting to go through the proposal, because proposals take a lot of work to build, process with other entities, because that sounds like a question we don't know the answer to. And then there's also option number 3. But my guess is the consortium may be looking towards that expansion and bidding on RFPs, or they may not. I'm not sure.
So, Donna, do you want to take that?
I can, or you can.
I was just going to say, we're always looking for opportunities to expand. We understand that there is a time investment in reviewing all of the requests for proposals. And we also work very closely with our contracted partner, MOTA Health, to resource the responses to those. However, as we've already kind of highlighted and noted, is that there's opportunities to collaborate. And it sounds like your procurement office is echoing exactly what my procurement office has told me over the last 4 years of me in this position. And that is, the more that we can cooperate with other states, the better off we will be. So I hope that answers your question as it relates to what we're willing to do as a consortium, and we're open to both paths, whichever allows us to see the growth that we want to see, and that will ultimately mutually benefit everybody involved, right?
Yes, this is Betsy again. So at this point, the consortium is starting to reach out to other states. I'm asking, I guess.
Absolutely. Maybe it's helpful for me to just paint a little picture. There's been a great deal of outreach through many different organizations, the National Governors Association, the National Academy of State Health Policy, some other large organizations. And we've actually had conversations with other states, testified in other legislatures, and even in other had conversations with territories of the United States. So to say that there is interest in the consortium is an understatement. There is a willingness to sit down with us and speak to us about all the options available to states. And we're excited that Nevada is one of those states. And we're also excited that Nevada's closer than many of those other states. And it makes for a very logical partnership.
Chair Freed, it's Michelle here. I have some questions if Betsy's finished.
Of course.
So I would actually, to keep on the same track, we're on the contracting track. A question for Executive Officer Rich. Executive Officer Rich, you indicated in your report that one of the reasons you're recommending option 2 or 3 was negotiating risk. And I just wanted to delve into that a little more. Can you talk to us, perhaps tell us what are some of the areas where you see negotiations breaking down, or if that was just a general statement because risk exists in everything we do?
Laura Rich for the record. So it was just a general statement, right? I mean, we've had these conversations. I don't see anything that we've asked a lot of questions. I don't see any issues. But I mean, I'll just give you an example, and we know this is not the case, but we could get, down the road and then figure out that they cannot accommodate our July 1 to June 30th plan year, that perhaps that we have to use the existing January to December plan year. That's a deal breaker for us, right? So that's just an example, of something that we could come across down the line where, oh no, this is not something we have no ability to even negotiate this. And so while we don't have any of those that are, that we've discovered so far, it definitely is a risk knowing that we wouldn't have a plan B. So that's a concern from a program perspective, is that, we haven't negotiated this. We haven't gone down the road of a contract, right? And so whereas with option 3, we could go down that line and go in through the negotiation process with the consortium and negotiate a final product, and then that product would then be the board would then consider it against the negotiated final contract through the RFP process too. That, yes, it does add a lot more work onto staff, because now we're negotiating 2 contracts instead of 1. And with all of the RFPs that we've got out, it's an extra burden, but it's one that we're willing to do if necessary. And I think that this is a good option. It's a good option to explore, but we want to eliminate the risk of getting down that road without a solicitation and not having a plan B in place.
So just a follow up there, and I apologize for putting you on the spot, but this is a really interesting conversation. So generally in health insurance, covering more lives is better than less lives, right? I mean, that's a general principle. Would you agree with that?
Generally, that is true, yes.
I guess what I'm struggling with is that, I know PEVP, like I'm assuming the PBM, I'm thinking about how I legally am allowed to say this. I'm assuming that the PBM RFP is one of the more complicated RFPs that PEB does. And so the time and obviously the cost, because I would think that we can't do an RFP for a PBM without employing a consultant to help delve through the data and the numbers. So there's that cost, there's the time cost. So I guess I'm struggling. I understand your risk aversion and applaud it. You know, we've obviously, generally RFPs are a good thing to do. I guess what I struggle with is that the consortium is actually just a big RFP committee, if you will. And I'm sorry to simplify everything that everyone does, but it's just a big RFP committee that, you know, that meets, it has more lives. I would think it can negotiate a better product than we could on our own. And so I just struggle with, while I understand the due diligence, I struggle with the time and the cost of doing option 3, honestly. Yes.
So let me just, let me jump in. There's a couple things. So yes, we are leveraging population. There's an obvious advantage to that. There's also the population in the sense where, you know, CVS, ESI, those giant PBMs, they have a much larger population to leverage across, you know, their book of business. So there's the argument that they could potentially provide, you know, better services at lower cost. Now, I don't know if that's the case or not, but there's that 2-part equation of, yes, we could be joining and getting, you know, using our larger population to get a better, you know, better pricing. But then there's that other argument as well. And like I said, I think this is a great option. I'm just, you know, as the executive officer, I need to present all the facts, and I definitely do not want to, you know, prefer one option over the other, or one vendor over the other. That's something that an evaluation committee would do, or, you know, the board. But yes, you are correct. There's an argument that there's a lot of time and effort involved in a procurement. You know, you've been on several of them. You know how much time and effort is involved in developing it, and, you know, going through and just from start to finish. And then there's, again, the negotiation and that whole phase too. So there is an argument there that is it worth our time and energy to go through a procurement process. I also want to bring up the elephant in the room. We do have, you know, an audit that, you know, came out not too long ago that came down on PEB for their previous lack of, you know, of going out to RFP and solicitations, timely solicitations. That can be interpreted in a couple different ways, because, you know, on one hand, this is a legislative audit. You know, there was an intent there that PEB needs to go out to bid. We need to, you know, go out and see what's out on the market. We cannot be extending our contracts like we have been in the past. However, on the other hand, you've got the same, you know, legislature saying they're passing legislation that is encouraging exactly what we're doing, right? Or what we're considering here. So there's a lot of arguments to be said either way.
Yeah, thank you. And, you know, I understand your position, and I just wanted to, you know, get some of it on public record. But I also, if you don't mind, Chair Fried, I have a couple of questions for the consortium, participant-facing questions.
Please.
Yeah, so my first question is, and I'm not sure who to address it to, so I'm just going to ask it and you guys can pass it around. But do you get participant feedback in a structured manner regarding the pharmacy product generally? And if so, how is that solicited? You know, how often, et cetera, et cetera?
So this is Donna, and I'm going to probably tag team with Robert just to tee you up. So the contract does have a provision for an annual member satisfaction survey. So it's a pretty broad section in the contract, and it would be more specifically negotiated on a program by program basis with MODA. So Robert, do you want to explain kind of what you do for your member satisfaction surveys?
Yeah. So thank you, Donna. This is Robert Judge. So we work with our participating programs on developing customer sat surveys that work for them. So generally, there's a question set that we arrive at, and that's what we use to kind of put it out there. And there's a variety of mechanisms we can use to do that. So there's definitely a member feedback mechanism that we solicit on. The other side of it, though, is kind of programmatic issues, and we get at that a couple ways. So the consortium meets with us on a weekly basis, and we have a task log of all the various elements, not only the consortium's doing, but what each of our participating programs are attempting to achieve or wanting to achieve. And so that kind of keeps the consortium informed of what all the participating programs are exploring, but it also kind of feeds a mechanism for program development, or I'll give you a great example. So the state of Washington, public employees, well, the state of Washington in general, about 3 years ago, as the opioid epidemic was taking off, came up with a set of policies and standards that they wanted to have established for Medicaid and the public employee groups, corrections, and others. So when that mandate came down, we worked really closely with the Uniform Medical Plan, which is the public employee plan that participates in the consortium, and the consortium benefiting agencies, the kind of the oversight organizations, Donna's organization that administers the consortium, to develop a set of policies that met the requirements for the state, but were reviewed not only with the health plan themselves, but with the consortium in terms of how we implemented it. And so we get feedback that way. And it's I think you're getting a sense that the consortium is not rigid. It's very collaborative, and it's very cooperative with participating programs in terms of kind of what the program elements need to be, how they need to be adjusted, and how we provide continued oversight and management of them.
Great, thank you very much. And so there's really nothing you could share with the committee about overall satisfaction then, because it's program by program based?
Yeah, that's correct. It's each kind of, we have some that do the CAP survey, so it gets set up that way. We don't do a kind of an aggregate member survey.
Michelle, this is Donna in Washington. Robert, sorry to interrupt. I can tell you that I usually only hear from members when they're unhappy. And so we don't hear a lot from our members. So I really think that there's an overall level of satisfaction with the consortium, or at least with the services that MODA provides. I think where we find there's dissatisfaction is more in the benefit design. The copay is too much. I don't like the formulary, which is dictated by us, the plan, and not the vendor. So I think that the services that MODA provides are actually very, very good and well received by our membership. And the dissatisfaction, like I said, really comes from benefit design.
Thank you.
This is Laura Freed. I have a question for the consortium folks, a couple actually. Can you talk a little bit about the scale of your pharmacy networks? You've got 1.3 million members over 2 states, and I don't know how many more sort of local entities. So which pharmacy chains does Navitus have contracts with?
Robert, I can kick that off, or do you want to?
Why don't I go ahead and address it, because it's, we're just finishing kind of the new build out. So we offer a couple of network options for participating programs. We have a broad network, which includes all chains and pharmacy services organizations that independents join and direct contracts with individuals. There's about 65,000 pharmacies in that broad network. Then we also have what we call core network, which allows us to get better pricing from the major chains if a chain is not participating. And we just completed that for the next start of the year, January, where CVS opted out of the consortium, and Walgreens, which had not been in the consortium, has opted in. But the benefit of being able to offer participating programs the choice of networks, and that is about 53,000 pharmacies in that core network. The benefit is there's a better guarantee that comes with the core compared to the broad that equals, in our analysis, a couple bucks claim in terms of beneficial pricing. Now, I will say that one of the things that we know we need to do as you continue to, especially if you expand into kind of the Atlantic states and we have conversations going on there, the pharmacy mix is going to be a little different. So the consortium is really receptive to creating different types of network structures depending on the geographic needs in which we're operating.
And this is Laura Rich for the record. I just want to add that currently CVS and Walgreens are excluded from our network as well for maintenance medications, and through as of this plan year, we narrowed that network as well, so that CVS and Walgreens are not included. So I just wanted to make sure that everyone was aware of that.
Can I just ask a follow on the networks, Jeffrey?
Sure, you bet.
Yeah, how about, I see that you work with Costco, so is the Costco pharmacy in the core network? How about Sam's and Walgreens?
Yes, Costco is in both networks. So both Costco's brick and mortar places are in there, as well as Costco as a mail service provider is in both of our networks. And Costco offers kind of an interesting program where they not only, you can use their mail program to pick up inside their retail outlets. So Costco is a really important player, I think, in kind of delivery here. But we have.
Sir, you're on mute. Mr.
Robert,
Judge.
we lost your audio.
Yeah, my finger, I might talk with my hands. I must be my ancestry. But anyhow, one of the things I wanted to say was, there's a lot of importance around having the national retailers involved and the big box stores and the supermarket chains, et cetera. But we also the consortium puts a lot of emphasis on kind of independence as well. And so they have a program called Critical Access Pharmacies, where it allows us to create differential pricing to keep those mom and pop pharmacies in rural, parts of the states out here in business. And that's factored into both the broad network and the core network.
Okay, this is Laura Freed again for the record. So a question about spread. If I'm understanding the presentation right, there is no spread on generic drugs, brand named, and specialty drugs. Is that right?
This is Donna Sullivan. That is correct. There's no spread on anything,
okay.
Even including rebates. So when MODA is negotiating rebates, we get 100% pass through of the rebates. And it's a pretty broad definition of what a rebate is. So it would include any claims, any money that the manufacturer might provide to MODA, administrative fees, anything that looks like a rebate, smells like a rebate, we call it a rebate. And that gets 100% passed through to the participating program.
So then what is the current per member per month cost?
So we have different ways that you can pay for the administrative fees. There's a per member per month, which I think is $2 and a penny per member per month. And then the per claim fee is, Robert, you're going to have to it's more than $2.01 per month or per member per month. It's a little bit higher. It's still less than $2.50 a claim, but there is a higher admin fee. And that's kind of the trade-off between transparent and pass-through, is that it looks like it costs more. We've, with the current vendor, we've looked at, should we offer a spread, to try to be more competitive with some of the other PBMs. We've looked at what would a spread or even a shared savings model look like. And for Uniform Medical Plan, it would cost us more money to go back to some sort of spread type arrangement because of that overperformance that Trevor had talked about. We're getting such a better discount on the drugs than we would, in a spread arrangement.
Okay, thank you.
And then I'm sorry, I don't want to interrupt. And
no, go ahead.
We can, we have our contracts. As we have with other states, we have a non-disclosure agreement. If we can enter into a non-disclosure agreement, we are able to share our contract terms with, with the state of Nevada, so that you can review it as you're trying to, make your decision on whether or not you feel like we can meet your needs. We're able to share with you those contract provisions. And to the point that Laura had made earlier, we already have programs that are not on a January through December cycle. We have one program that's, goes from October to September. So we're really able to accommodate, many different, needs from the different participating programs. And none of us are really, all of the programs are very different. Like our program in Washington, we have a custom PDL and then a wraparound PDL, where some other of the programs, really rely on MODA to do all of the clinical management, where in my agency, we have, 3 pharmacists that are really, focused on the public employees program, the school employees program, and a lot of other staffing. So depending on what level of support you need, MODA can really lean in, or if you want to do the management yourself, then they kind of lean out and they provide you with the support and assistance that you need to manage your program.
This is Laura Freed again for the record. Okay, board members, other questions or discussion?
Chair Freed, Tim Lindley here for the record.
Go ahead.
So I'm hearing a lot of positive things, especially from Director Rich, and significant savings. And of course, I hate to play the devil's advocate, but what are some of the difficulties that the consortium has encountered, and what have they done to overcome them? That's a question for the consortium.
Yeah, we have grown. I think that we have really done a great job in working out the kinks. Any transition from, one pharmacy benefit manager to another is always complicated. There's always, you're going to hit, bumps in the road. I've transitioned 3 times, a pharmacy benefit manager 3 times now in my career. And a lot of it is, I think, just, I'm going to go back to mail order. Mail order always seems to be the biggest, my biggest issue, where you're trying to get those refills, transition to the mail order vendor and something goes wrong. Or, now with the electronic prescribing, it's not as big of an issue where, faxes. Back in the day, we heavily relied on faxing prescriptions to mail order pharmacies, and they would get lost into the ether somewhere. I don't have any issues right now with the consortium. We have a great customer service. We have good support from the executive account team, but I can't guarantee that it's not going to have any pain points, but there's always issues that you can't account for. But MODA has really been committed to trying to get them addressed. When we first transitioned from our former PBM, like prior consortium days back in 2006, we did have a problem with our mail order pharmacy, and MODA assigned an individual and basically just took them out of their current job, and their primary focus was to fix the problem. And that became their full-time job until the problem got fixed. And so, Robert's probably cringing as I'm saying that would happen if we had an issue, but they are focused on getting the problem solved and working with you to get through it. And we do have performance, guarantees within the contract that, take that into account. So they are on the hook for if something goes sideways, if there's a performance measure or a guarantee with that, they're on the hook for administrative dollars, which they don't want to have to give up. So they are really wanting to make sure that they're over-promising and, under-promising and over-performing is what I'm trying to say.
I'll just add, I'll echo what Donna has said already as it relates to our contractor and my own experience. I just give you an example of an issue that arose that we actually got turned to the consortium for help on. Our Medicaid program had a sole source Medicaid mail order pharmacy solution, and that company decided to give us 30 days notice of terminating, which that's just clearly not enough time to transition to a new mail order solution. However, the consortium had a mail order solution, and we did the impossible, and we transitioned our Medicaid program to that solution inside of 30 days with Moda's help. And so that should illustrate to you the nimbleness, the flexibility, and the commitment to service excellence that I'm used to, and that I'm not letting go anywhere as a co-administrator of the consortium. I'm holding our contractor to that same expectation of best-in-class customer service. And I think, Robert, you're probably going to say a few things because I heard your voice. So go ahead.
Yeah, it's not all rainbows and unicorns all the time. There's whenever you manage a prescription drug benefit that's specific to a group, you encounter challenges either in how do we configure that particular requirement, or how do we enable this type of capability. But I think one of the things that both Donna and Trevor have represented, and as the MODA representative here, I'm in total agreement with, is we may not have the solution right there, but we'll move heaven and earth to find that solution. And we've dealt with all sorts of complexity. For instance, we provide workers' comp through the consortium, and workers' comp is a different animal. And the workers' comp organization that we support has 7 different formularies. And so we programmed 7 different formularies, one that's just specific to monkey bites at a research hospital. So there's a lot of complexity that we have the ability to administer and address. And the way that we accomplish that is through really open communication and dialogue with our clients. It's not here's our solution and these are the things you can nibble away on. It's how do we make this work for you and your members? And that's the point I think that's really important to understand about the consortium. I think makes it somewhat unique in kind of what it does.
This is William Hayes for the record. I also want to offer a negative, just so that you have an option to look at. The Department of Corrections has a very unique component of the consortium that we call the voucher program. In the Department of Corrections, we have to obtain emergent medications. Those come from a retail pharmacy near our prison locations, that we use the voucher to obtain those medications under the consortium pricing at no cost to the individual that's picking it up, but it's charged back to the prison organization. There are people with the same name and the same birth date that I found out across the country. And due to the way that insurance systems work, somehow pharmacies are able to pull in insurance information and bill insurance for an individual that isn't the individual that is actually the person that's receiving or that actually has that insurance. And due to my due diligence, I was able to capture that somebody billed my insurance for a medication that we didn't actually purchase. And I'm working with MODA to evaluate how we can prevent that from occurring moving forward. So there are things that occur, but MODA is working with us to figure out how we can prevent that from occurring in the future. So I again echo that there are challenges, but the consortium is able to move forward and figure out ways to prevent those from occurring.
Chair Freed, Tim Lindley here again.
Go ahead.
I just wanted to bring it kind of my remarks back to the presentation and then the options in front of us. Given the recent legislative audit, I think it would be wise if we took that into consideration and proceeded with an option 2 or 3. And I just wanted to share that and express that with other board members, because we were found to extend contracts, and here we are at a juncture where we would typically do an RFP, and it would be wise if we took the legislative audit recommendation and did an RFP, either an option 2 or option 3.
So it's Michelle here. Can I just kind of, I guess I would like to discuss that because, yes, the legislative audit was quite scathing, but when you actually have a look at the number of products, it was all the products that they were extending and they weren't doing due diligence on. And I think that Executive Officer Rich and her team and the board, right, this year have spent the year putting every product they had extended under the RFP umbrella. And so I think that I personally would hate for the plan to incur lots of costs unnecessarily to placate an audit that really the team's already done due diligence with. I think for me, the legislation, the statute encourages this behavior if we kind of rely on what Gideon shared with us or purchasing shared with us. And it just seems to me that, it sounds like the consortium does their due diligence. So we're actually building into an RFP that's already run. So they're not just going out and individually shopping. We'd actually be purchasing into or stepping into an RFP that's been run. But also, I just think that the scale of findings in the audit, the fact that the team has already satisfied probably around 90% of those findings, I feel better about opting into a consortium such as this, especially since it's encouraged. We're not recreating something here. We're not trying to push a boundary. It's actually encouraged by the legislators. So I guess I just wanted to have a discussion on that point, because I do think, I think that, as I say, the time and the cost and the effort, purely because we got dinged on an audit that has been taken very seriously and satisfied, it would be concerning to me to make a decision based on that alone.
Member Kelly, Tim Lindley here for the record, and I appreciate you opening up the discussion for that. One thing I've learned in my years of government service is just because it's easy doesn't mean it's the right thing to do. And the audit did say that the contract extensions didn't reveal or show that we were getting the best bang for our buck, the best services for our members, and that's why I was leaning towards 2 and 3. So then we can definitely review not only the RFPs, but can prove for a fact that we are getting the best dollar for our members and for the state.
This is Betsy. I have a question again about the actual consortium. Has the consortium had anybody or any entity that was part of it that decided in these years that it wasn't the right way for them and left?
Yeah, this is Robert Judge. I'll answer that. So we have a teaching hospital, Oregon Health Sciences University, that was part of the consortium, and they left 2.5 years ago, when they established their own, and we handled the employees of that hospital system for the consortium. They created their own pharmacy benefit management program because they had access to academic institutions 340B pricing, which is kind of akin to Medicaid net pricing. And because of that, they said they can leverage their access to prescription drug prices and they established their own PBM. So they dropped out.
This is Laura Freed. Keying off of Betsy's question, which public agencies in Oregon and Washington have elected not to choose or not to participate in the consortium, besides Oregon Health Sciences?
So this is Donna in Washington. So right now we have our Department of Corrections, Department of Labor and Industries, and the Public Employees Program are participating. Our Medicaid program just reprocured for their fee-for-service platform. We manage our Medicaid program pretty much in-house. We just kind of rent the platform. The MOTA was not selected for that particular program. And then other programs have actually demonstrated that they can purchase cheaper. So we have the Department of Health has the Ryan White, the AIDS prescription drug program. They have federal funding that make it more advantageous for them to go down the road that they're going. And then the state hospital, although it used the same group purchasing organization as the consortium used, is not an official member of the consortium, and I think they didn't join because they're using the same services, the same vendor that we are already offering. So most of the programs that can join have joined.
And for Oregon, very similar, and we, as evidenced by Bill Beck's participation as in the steering committee, our psychiatric state hospital it has been a great partner. We have the public employees benefit programs and the Oregon educators also participating, where MOTA is the underwriter of the medical benefit for those members. We also have Safe Corporation that is the workers' compensation plan that was alluded to by Robert Judge earlier. And then we're continuing to have dialogue with other agencies that do purchasing and have interagency conversations about the benefits of working with the consortium all the time.
So this is Betsy again for the group, and the discussion regarding should we do an RFP or should we not do an RFP? One of the things I'm thinking about is, this sounds really, really great, but I can't imagine the big pharmacy benefit plan industry sitting still and saying, we're going to just be able to lose all our contracts because this entity is so great. And with people looking at this, a couple different things. Also, Director Rich had mentioned that maybe some of those pharmacy benefit managers are huge enough that they're able to negotiate real pricing. So a question would be, could an RFP be written into an administrative cost versus a spread with transparency, and see if that's what we're looking at that we want, see if that was available, and or if pharmacy benefit programs, which being this is a public meeting, are probably hearing how much we're really looking at some of this and maybe going to compare a bid they made against something like this. Would they come in with a different type of bid if this didn't exist? Not to say that government entities working together, I'm totally a proponent for, because the more smaller things you have, duplicating administrative is difficult, but I'm wondering if some of this might generate extra competition. Just throwing out some thoughts going on in my head.
So Betsy, this is Laura. We do have a couple of people on the line that can speak to that as far as the RFP and what kind of RFP we can develop, and if it's something similar to what is the model that is being provided by the consortium or by MOTA Health. So I think either Stephanie or Nathan from Aon can speak to this if either one of them want to just chime in.
I was going to let Nathan chime in since he's more in our pharmacy group. And as you all know, I'm more on the actuarial side.
Sorry, I was speaking on mute. This is Nathan Casson with Aon's National Pharmacy Practice. So that would be exactly the preferred method would be to take the transparency requirements that we're looking for in the contract, build the RFP to solicit bids from that, and then ultimately use the market competition to drive down and a proof point to see if this option, which so far with our analysis has, yielded savings, if this is the absolute best that the market can yield. And I think we don't know what we don't know at this point. However, I think due diligence and market competition will give us that proof point and ultimately the transparency requirements that we're requiring.
Tim Lindley here. Something to go along with that, if I may, Chair Fried.
Of course, yep.
I just wanted to say first, preface that, or just wanted to say that I do understand where Member Kelly's coming from in regards to option one, and I respect that, and I do see that we do have the ability to choose that. Also wouldn't have been presented for us. One question I have, and maybe just some clarifying questions for the consortium, how many members do you have?
We have 1.3 million members.
All right.
And that includes the discount card for all transparency, which is probably close to half of that. The state of Washington Uniform Medical Plan, we have 289,000 covered lives in the public employees program, and probably 160, and I might be overstating the school employees because they're new, but we have about probably 350,000 lives just from the state of Washington alone in the program. And as we grow and get larger, the admin fees do come down.
All right. So the next question I have, and I found an answer for that I wanted to share, is Express Scripts, according to Google search, has 83 million members. And I'm looking at the presentation regarding the consortium, slide 16, value of pass-through. And one thing I wanted to share, 1.3 million members, and they were able to find savings compared to a larger PBM. And that's just an observation I wanted to share.
This is Laura Fried. Okay, I haven't heard from a couple of board members, and I'm trying to get a sense of the board based on this discussion and the questions posed to both state staff as well as the consortium folks.
This is Tom Verducci for the record, Chair Fried.
Yes, sir.
In hearing option one, I do hear the argument. I did hear Executive Officer Rich use the word risk with option one, and that's where I would be concerned. I do think an RFP does create a document. It does give us the ability of negotiating. It's in writing. It's a competitive structure. I was on the board when we did a 2-year extension with this contract to save $2 million a year. And we fell under the audit that perhaps it was not the right thing to do. And the only way I would want to skirt the RFP process is if we did have something that from IFC and the GFO that was encouraging us to move forward. But my observation would be that we do go through an RFP process under either option 2 or 3, so we could take our time and evaluate it and make sure that we are not jumping into uncharted waters where there's not a full analysis that we should undertake. So I think option 2 and 3 would be the better choices. And I'm trying to realize how if there's an advantage with option 3 that we could cancel a winning bidder. And I don't know if that's the way to go. I'm kind of leaning towards 2, but I do think those are the 2 viable options, in my opinion.
Okay, thank you.
This is Jennifer Krupp for the record. My recommendation, or I guess my sense, would be to lean towards option 3, so that we could accurately make essentially an apples-to-apples comparison between PBMs that might bid and the contract with the Northwest Consortium.
I tend to agree with that. Thank you. Thank you, Member Krupp. Anybody else have comments?
Just to reiterate what Jennifer had said, I also feel that option 3 would probably be our best bet and tend to lean towards that.
Okay, thank you very
Michelle
much.
Kelly here. I can get behind option 3.
Thank you. All right, well.
If no other board members have a question, I actually do have a question that I would like to ask the consortium.
Of course.
This goes back to the market check. How is that market check performed? Do you guys do it internally, or for example, today we have our consultants who can leverage their book of business and are able to do that market check using that book of business. Is that something that PEB could continue to do, or how is that market check done?
Robert, do you want to take that?
Yeah, I'll go ahead and address that. Thank you, Laura. This is Robert Judge, for the record. So we use a national consulting house to do the market check, and actually they're market checking kind of the rates that MOTA and Navitus administer. So we're not, it's not the fox watching the henhouse. It's the market checks are done on behalf of the consortium, and it's reported to the consortium annually. They use, there's a couple of unique things about it. They use their book of business, and it's a recognized consulting house that I'd be happy to share under disclosure. But what they are doing is they market check comparably sized organizations. So we're market checking groups from 500,000 lives to 1.5 million lives in aggregate. And that's what the benchmark is against. And then, as Trevor mentioned, if the value of that is outside of a narrow percentage, then the consortium then mandates that we go through a recontracting process.
Okay, so just follow up, and I know that Dr. Slamowitz would like to chime in after myself. So does this vendor that you use, do they have an extensive book of business? I mean, we use a vendor who has a very, very extensive book of business. So I'm just wondering, how much of a comparison pool do they have when they do this?
Yeah, so the consulting house is almost identical to your consultant in terms of kind of girth and size, and the book that they use is all recently completed RFPs. So when we do it, we understand for each member in the cohort that's measured, we know where they are in their life cycle of that contract, with the goal of trying to get as many into first year of contracts as possible. So it gets as close to kind of present day as we can. That market check also looks at kind of not only backwards, but where's the market going? And they give the consortium kind of an assessment of what they expect the future market to represent in terms of movements in brand and generics by channel. But Laura, it would not be a surprise to the PEB board or incur doubt in the PEB's board about the kind of the capabilities of this consultant.
And Laura, this is.
And I will say, sorry, go ahead, Donna.
Sorry, Robert, I thought you were done. I do want to say that the consultant has found that MODA's rates were kind of stale and not as good as they could have been, and they were outside of our parameters. And so we did renegotiate our contract, and we did get lower rates, and we saved over $1 million in drug costs. So it's not just a rubber stamp saying, yeah, MODA's great and their rates are perfect. So I really feel like we are getting a good unbiased evaluation of our market check.
Thank you so much. And I think
Can I ask a question, I guess?
I'm sorry. This is Laura Freed. Who had indicated they had a question?
It's Michelle Kelly.
Okay.
I have a question for Executive Officer Rich, or perhaps purchasing.
Okay.
I'm just wondering if the board goes in the direction of going with 2 or 3, regardless of which one, can we? It's my understanding that PEB and PEB executive staff would much prefer the fully transparent PBM model, right? I think that's the direction we're going in, so that we can see everything and understand it. So when we build the RFP, can we specify that's exactly what we want? We only want people to bid on the business who are going to offer that fully transparent model. All the pass-throughs, the rebates, the specialty, all of it.
This is Laura Rich. Yes, that was our intent. Yes.
I have a quick question. This is Jennifer Krupp for the record.
Sure.
If we did build the RFP with those provisions that Board Member Kelly had just mentioned, would there be a risk of fewer PBMs bidding to complete the contract?
This is Laura Rich. I don't believe so. I think we're still going to get, we know pretty much who's going to bid. There's not 100 PBMs out there. You've got, the big ones that are going to bid, and then you might have a couple small ones. So we're not, we don't expect to go from 15 proposals to 2 because we go this route. It's likely going to remain about the same.
So, Tom Verducci for the record. I did have a question on the difference between option 2 and option 3. As I read 2, it appears that the consortium they would have to submit a bid, but under 3, there would be no submission of a bid with the consortium, and then PEB would have the option of adopting the consortium as a choice. Is that correct? So they bid on 2, but on 3 they do not bid. Am I reading that correctly?
This is Laura Freed. Yes, that's correct. 2 requires them to, 3 permits them to, but they don't have to. So in that sense, I think 3 gives the board more flexibility.
Just as a follow-up, Chair Freed, would there be any advantages in having them submit a bid in option 2 that could end up in a negotiation of the contract, or would 3 be an assumption that we would be just adopting their current master contract or interlocal agreement, or however that's adopted?
So this is Laura Rich. I think the intent here is to go down 2 paths with option 3. It's to negotiate a final contract, proposed contract with both entities, the winning vendor and the consortium, and then the board then through a closed meeting gets to evaluate those 2 negotiated contracts and gets to choose which one they want to go with. If they want to go with the winning vendor, then that's easy. We just go down the normal path and and award it just like we do any other contract. If we want to go down the road of the consortium, then at that point the RFP is canceled and we stop those negotiations and continue with the consortium and contract with them in the appropriate manner.
So with option 3, as I'm hearing it, that would provide us the maximum amount of flexibility and decision making as opposed to 2. Am I reading that correctly? That we have more flexible choices available under 3?
Correct. It is the most work as well, because we'd be doubling our efforts going down 2 paths, but it also provides the most flexibility and provides that the board the ultimate decision as to which decision, which PBM we'd go down, we'd work with in the end. Whereas a solicitation, while board members are usually involved in, as part of those evaluators in the evaluation committee, the board as a whole is not the evaluation committee. And so, the board just gets to check the box, yes or no, and we move forward with the contract or not. But the actual evaluation happens through a normal solicitation process. So that's the difference, is the board would get the choice with option 3. Whereas option 2 does not provide that choice. However, it is obviously, a less of a lift for staff.
Okay, this is Laura Freed. I would like to wrap this item up. We've been at it for 2 hours, and I've gotten a sense of the board. Dr. Slamowitz has indicated she has a comment to make, so I'll let her introduce herself for the record and make a brief comment.
Thank you, Chair Freed. This is Beth Slomowitz. I'm the Senior Policy Advisor on Pharmacy for the Department of Health and Human Services. For the record, I just want to make real brief comments. I know time is short here in terms of just providing some context around the PBM and the RFP process. Having just concluded that process for the fee-for-service Medicaid solicitation that we did in conjunction with the Ryan White program. I don't think anybody here can underestimate the amount of work that goes into an RFP development, as well as, that evaluation committee. To Laura's point, Laura Rich, the responses that we got for that RFP were, the traditional PBMs. And I want to just kind of make it a point in that with the consortium and their solicitation that they just concluded, their last RFP was released in 2020. The same PBMs had the option to respond, and those large PBMs, such as Express Scripts, chose not to. And so I think that's of note, that there are transparency requirements, audit requirements down to the claim level. There are market checks and things that I think some of those larger PBMs aren't to the point where they're comfortable with responding in that way. I think also of note is that, the larger PBMs, while they had the opportunity to respond and chose not to, the bid process that we went through on the fee for service side, some of the responses that we got back were over 800 plus pages. We tried to put information into our RFP in terms of what our transparency requirements are, but there were still pieces of their responses that were considered to be confidential in terms of some of those contracts and things that occurred with their pharmacies or networks. And so all of those things I think are important when you're considering how you want to move forward. I also put a lot of time into the legislation, the SB 396, in terms of, expanding the current statutes that allow states to work collaboratively. That was part of the reason why fee-for-service Medicaid decided to do a dual solicitation with the Ryan White program, rather than having 2 separate RFPs because of the cost and the work. And I think we benefited in terms of what we got and reduced administrative fees. Last point, I promise, wrap it up, is that the RFP process is, in terms of when you get the responses for the RFP, I think it's important not to put all your eggs in one basket in terms of, cost. It was important for us not to make that a deciding factor because PBMs are inherently complex and pharmacy benefit management is inherently complex. You really have to look at the outcomes in terms of the benefits that you're getting for your members. The consortium is really, their onus is to the taxpayers. In large PBMs, really their onus is to stakeholders and stockholders. And so all of those points, I think I just wanted to put out there for everyone just to keep in mind as you decide what process you want to go through and what outcomes you really want for state employees and their pharmacy benefits. Thank you.
Okay. Again, Laura Freed for the record. Board members, I could use a motion to move forward with this item.
Tom Verducci for the record.
Okay.
I'd like to make a motion. We move forward with option 3.
Okay. Thank you.
Tim Lindley for the record. I will second that motion.
Okay. Thanks. All right, board members, you've heard the motion. Do you have any questions on it or discussion on the motion? Okay, hearing none. All in favor, say aye or raise your hand in your little box.
Aye.
Aye.
Aye. Aye. Any opposed, say no. Okay, hearing none. I think that motion carried unanimously. Wendy, tell me if I'm wrong about that. Okay, thank you, everybody. I appreciate the discussion. Ms. Sullivan, Mr. Judge, Mr. Douglas, Ms. Vasquez, thank you very much for your testimony. And with that, I think we will take a 15-minute break and then we will recircle back to the top of the agenda. Thanks, everybody.
Thank you.
Thank you.
Thank you.
Give everybody another second to get back on. All right, it's 11:30 a.m. I'm going to call this Public Employees Benefits Program Board meeting back to order, and we will go straight to agenda item number 3. Take it away, Mr. Keegan.
Thank you, Madam Chair. Peter Keegan, Deputy Attorney General for the record. This agenda item is to allow me to make a disclosure on behalf of the board members who are eligible for PEB benefits. Several of the items on today's agenda have a direct or indirect effect on those benefits. Pursuant to NRS 281A 420, on behalf of the board members who are eligible for the PEB benefits, I'm offering this disclosure that they will be voting and have already voted on agenda item 6 regarding benefits that will affect them or may affect them and their family members. I know that the law does not preclude them from voting on these items. And I would invite any member that has an additional ethics disclosure that they find would be particularly relevant to any of the agenda items to make that disclosure now. Thank you.
Thank you very much. Hearing none, we will move on to agenda item 4. This is the consent agenda. And so as per usual, I'll ask the board if there's any of these items that they'd like to pull for discussion. If not, I will accept a motion for approval for the whole group of them.
This is Betsy, and I would like to pull 4.4 just for Aon to give a real quick summary of the high and low points because I was having trouble following the whole item.
Okay. So that is the FY21 Opeb valuation. Okay. Any other items?
Yes, Tom Verducci for the record. I know we don't have representatives that we're expecting on this call from Willis Towers Watson, Hometown Health, but on 4.3.5, 4.3.6, I just wanted to discuss 2 performance guarantees that were missed if we were anticipating collecting the performance guarantee amount, those 2 items.
Okay, thank you. Anything else? Okay, with that, I'll accept a motion to approve everything under agenda item 4 except for 4.3.5, 4.3.6, and 4.4.
Jill Kelly, so moved.
Thank you. Do you have a second?
Betsy Aiello, I'll second.
Thank you. Okay, it's been moved and seconded. All in favor, say aye.
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 Aye. Any opposed, say no. Great, motion carries. All right, with that, I think I'll hand it off to Executive Officer Rich to talk about 4.3.5 and 4.3.6 briefly.
So I believe that we do have someone, they weren't going to be able to be on until about 10, but our agenda item went quite long. So I do believe that we have Chris Garcia possible on the line. So I think he can speak to that.
Yes, hello. Hi, this is Chris Garcia with Willis Towers Watson's Individual Marketplace. In regards to the penalty for the missed service level agreement measure, which is reported on our Q3 2021 quarterly report, we are paying that penalty to PEB. I believe that was the question that Mr. Verducci had.
Well, Tom Verducci for the record, and thank you very much, Chris, for clarifying that. I know there's been a recurring issue with the call center, I think within the performance guarantee, the calls have to be answered within so many minutes. And I know there's been a reoccurring issue. Is there anything going on with your call center staff to alleviate and correct that reoccurring problem?
Mr. Viducci, thank you for the question. Again, Chris Garcia for the record. So with the mismeasure for this reported quarter, so fiscal year Q3 2021 or calendar year Q1, we were actually really on target to meet our 2-minute average speed to answer measure for that specific quarter until, if you recall, back in mid-February, there was a large winter storm that hit Texas. And one of our service center locations is in right outside of Dallas. It's in Richardson, Texas. And so with that area being impacted, the storm hit on actually Valentine's Day, if you recall. The following business day, which would have been the following Monday, there were so many power outages, and our service center in Dallas was virtually closed during that time period. And the folks that were trying to work from home had connection issues, et cetera, to be able to help customers. And we had to filter those calls to our other 2 service centers, one which is in right outside of Salt Lake City, and the other is in Tempe, Arizona. So while we had coverage to handle calls, the wait times were much longer than anticipated because we had to shut down one of our service centers, and those that could work from home had sporadic access to power, internet, et cetera, to be able to help callers. So that was really the cause that impacted our service delivery for that quarter. We feel that if that storm had not hit and the service center didn't have to be virtually shut down for that period of time, we would have met the measure. So while we know that we've had issues, in particular in Q4, which is our busy time of year, calendar year Q4, that's our busy time of the year due to Medicare open enrollment. We felt that we would have met the measure for calendar year Q1 if that storm had not hit.
So, I mean, given, there was extenuating circumstances related to weather here, I'd almost be pushing for forgiveness on this penalty in terms of the guarantee. But I think since it has been reoccurring and it has come up, that I would encourage the board to move forward with collecting the performance guarantees, because a guarantee is a guarantee. And Chris, I always feel bad calling you up here. I know this is out of your control, but the guarantees are what they are, unless Executive Officer Rich sees an extenuating circumstance, and perhaps an argument where it should be forgiven. But my opinion is we move forward collecting the performance guarantees just because they are in the contract, and contract is a contract.
Okay, thank you. If you don't have any more questions, then we can go on to 4.3.6 if you wish.
Yes, please.
All
thank
right.
you.
So on 4.3.6, our contract with Hometown Health Providers has ended. We transitioned, you'll hear me talk about in the executive officer report, to the Aetna network. And because of that, we have nobody attending from Hometown Health, and there's no contractual requirement for them to attend. But I will say that their performance guarantee totals, their penalty of the missed performance guarantee totals about $7,200. And so we will be collecting that.
Tom Verducci, for the record, that answers my questions. And I think at this point, I'm willing to make a motion to approve 4.3.5, 4.3.6, and collect the performance guarantees as a motion.
Okay. I think I'm going to hold on that because I want to take 4.4 in the motion along with it. So put a pin in that and let's move on to the OPEB valuation.
So yes. I believe we have someone, oh, sorry, go ahead. We have someone from Aon to speak to that.
Yes, hi, this is Andy Woody from Aon, if everyone can hear me okay. And I'll go over this report very high level, otherwise we'd be here for another hour and a half. But basically, what this report represents is, like a lot of other states, you have a benefit that you're paying to retirees that is essentially unfunded, which is common, of course. And the way this works for the accounting purposes is you're supposed to account for these benefits by valuing how valuable they are, both for current actives who can retire in the future, as well as for current retirees. The obligation is based upon use of a discount rate that's pretty low. It's based upon a municipal bond rate, usually 3%, 2.5%, 4%, whatever, depending upon the market at the time. The plan, as you probably all know, was closed to new entrants about 10 years ago. So you're not really adding to the pile. It's kind of a set group, but it's still, very significant. The liability on the books right now is roughly $1.5 billion for that obligation, and you expense for that on an annual basis. The expense is about $75 to $80 million a year. That's greater than your pay-as-you-go costs because the cost is based upon current employees as well who are earning towards a benefit in the future. So if you have a 50-year-old who was hired when they were 35, even though you're not paying any money to that person, they are accruing a liability. And as everyone on this call is very familiar with, the so we expect medical costs to escalate in our evaluations in general, so to the 2 or 6% a year long term, and we discount those liabilities at like 2.5% this year. So that's the basic concept. I realize I could go into much more detail, but that's the basic premise. If you look at the last 4 years, the liability has hovered around the $1.3 to $1.5 billion range. We are at a little bit of a low point in discount rates, which means we're at a high point in terms of the liability value. So we might see some stabilization and some reduction in that value over time, because as people die, as people retire, go past 65 and become cheaper, there will be some reduction. But right now, it's a pretty significant liability. And as I said, it's not funded. So I can certainly answer any questions. There was a specific question related to the situation at hand, but that's the 30,000-foot summary of the report.
No, this is Betsy. That helped me understand what I was looking at. I didn't know what I was looking at. Other than when you say it's unfunded, the idea would be that other than when you say it's unfunded, the idea would be that the current employees at that time would then be covering the current retirees at that time. Is that it?
Well, basically, it's maybe the simplest way to put it is it's essentially a pay-as-you-go obligation, essentially. So the state is paying for it. So if you didn't have the retirees, there would be $50 million that he paid last year that he wouldn't have had to pay. So I'm not sure I'm totally answering your question, but the active liability, the active people working right now for you, you're paying that as you go as well, but that's paid through employee contributions and retiree and state subsidies or contributions. But that's considered pay as you go, and that's normal. But for a retiree group, since they've already provided all the service to you, it's really more of a hit to your balance sheet because that's a liability that you're not getting any services for. But the funding is pay as you go for both plans essentially. But the accounting for the post-retirement medical plan is a little bit more, for want of a better word, conservative because any liability that's out there, you're not getting any services for it, so you kind of have to accrue for it over the course of time. Another way to think about it is you have someone who's working for you right now, you're paying their current active life, their current benefits, but you're also paying for when the person hits 64 and they retire, you're also paying for their benefits from 64 until they pass away. So it's kind of a double hit on the accounting side. On the pay-as-you-go side, That's more easy. That's easier to understand. That's simply what you're paying each year. So I'm not sure if I answered your question, but that's my answer. Anyway.
So it's Michelle Kelly here. I just have a quick question. Sorry, Jeffrey. So your explanation. So right now, active employees, yes, there's a monthly premium. And I know for retirees, I know each employer is also paying a set amount for me and for all of my colleagues. So where does that money go? And that's for for that future benefit.
So I feel like, okay.
Sorry. So there's two numbers to think about. One is the pay-as-you-go cost, and one is the accounting cost. The pay-as-you-go cost is pretty simple. It's just what you think it is, which is people are paying and the state's paying, and the year's over and everyone's even. The accounting cost is you're essentially accruing for the future of. So again, if you have an active participant, 35-year-old working for the state, we are taking some accounting money and putting it into an accounting bucket, if you will, so that when that person does retire, we have some reserve for that individual. So it's an accounting concept. You're accruing for it, so that way you avoid a scenario where you have a liability that's humongous that no one's measuring, and when the person retires, they're owed essentially $300,000, but you have no reserve for it. You're blindsided because you haven't built up a reserve for it. If we're having this conversation 25 years ago, there was no accounting for these plans. And that's one of the reasons why the plans got so expensive, is because, well, it's free. Joe Blow is 43 and he's got post-retirement medical, but who cares because it's free. And so this accounting scheme concept was brought in order to remind everybody, all parties, that, hey, this is a benefit that's going to cost money down the road. We need to have a reserve for it. So, but the accounting should be kept very separate from the pay-as-you-go. I hope that answered your question.
So this is Betsy. Let me ask one more thing, maybe in another way. I am retired. So where's the money coming from to pay for me? I know I pay a small amount and I pay my co-pays and all of that, but
that's a great question.
My ex-agency is paying regularly, or there's a bucket that's invested somewhere that's paying?
I need to speak up. I feel like we're getting, Mr. Witt, that was a fantastic high-level discussion of an Opeb liability, but I get the sense we're talking about putting this into budget terms, and so I need to jump in. So PEB has done pay-as-you-go for both actives and retirees for a very long time. There was a blip in, maybe Laura Rich can help me out with this one, when they set up the Retiree Benefits Investment Fund. And I want to say this was 2007, but I can't rightly remember. And so PEB got a bill passed to set up an investment fund specifically for this OPEB liability. And they seeded it with a couple $1 million. Well, then guess what? The Great Recession hit. And they emptied out the Retiree Benefits Investment Fund to enable a lowering of the RGGI rate for all the budgets that pay RGGI. And so we have basically nothing in the RBIF. And in fact, we've emptied out the last little bits of dust that we had in the RBIF to make budget reductions in this last fiscal year. So the mechanism to put money away for future retiree healthcare liability exists, but we don't have any money set aside for it right now. So we do it in the rates. So the RGGI rate is set, Retired Employees Group Insurance, which is a percentage of gross payroll, assessed on every budget account that has personnel in it, is set to pay for the projected biennial retiree healthcare liability. That's what we do, and it's what we have continued to do. So we could, of course, administratively set, and by we, I mean the governor's finance office, could set the RGGI rate higher and divert money into that RBIF, but we don't. We just cover this biennium's retiree healthcare liability.
Thank you. I probably should know that, but I know it now, so thank you.
Okay, and I'm hearing total silence, but I see Mr. Witt might be talking. Do you want to?
Somehow I muted myself. I was just going to say that you make great points about the funding. It is possible to pre-fund these obligations, which would reduce your shortfall. Easier said than done, but as discussed, we are not pre-funding. Nevada is just paying straight away, pay as you go, which is the most common approach, but not. Some entities do pre-fund, in which case the numbers look a little bit different. But you're essentially like Social Security. You're paying as you go. So.
Anybody else have any questions on the OPEB liability? Okay, with that, I would accept a motion to accept the two reports under 4.3, 4.3.5, and 4.3.6, and accept the OPEB valuation by Aon under 4.4.
This is Betsy. I am moved to accept those reports.
Okay, thanks. Is there a second?
Tim Lindley, second.
Okay, thank you. All in favor, say aye.
Aye. Aye.
Aye. Any opposed, say no. Great. Motion carries unanimously. All right, let's move on to agenda item 5, Executive Officer Report.
All right, Laura Rich for the record. So on the Executive Officer Report, it's pretty short and sweet this time around. A little bit, some updates on just our operations. There's, as I say every board meeting, we have been very, very busy here at PEB. Staff are very engaged right now in all the work that is involved in getting this eligibility and enrollment system to go live by January 1st of 2022. The system obviously it manages most of the functionality that is used within PEB by PEB staff, but also by members, by, it handles our invoicing. It is very, very critical to the everyday operations of the agency. So we have a lot of staff dedicated to this, and a lot of staff is putting a lot of time and effort into this project. Our operations officer, Nick, is overseeing this, and the poor guy is on meetings probably 8 hours a day. So in addition, we have also been very heavily involved in smoothing the transition from the Hometown Health Network to the Aetna network. As we all knew, going from one network and transitioning to a new one, that has a lot of disruption on members. There's members that have doctors that they have been seeing, their providers that are no longer in network. And so they either have to find a new provider, or if they do qualify for some, to continue the treatment there's a statute that allows, if you're undergoing certain active treatments, you can continue to receive services through that provider at in-network rates for a certain amount of time. So both HealthScope Benefits and American Health Holdings have coordinated with PEB staff and with members to ensure that this process is as painless as possible for members that are undergoing this active treatment. So they have been reaching out to members. Members have reached out to me, to other staff. We've really been hand-holding as many people as we can through this process, because it is fairly disruptive. And so members need a lot of assistance and education, and between staff and our vendors, we've been attempting to do what we can to make it as painless as possible. Federal funding opportunities, I just wanted to provide an update on that. We did discuss at, I believe it was the last board meeting, it could have been the one prior to that, that there the state continues to have, they have not spent all of the coronavirus relief funds, so CRF or CARES Act funds. So PEB has resumed discussions with the governor's office, and we have requested, in addition to the $5.6 million that we received through December of 2020, we've requested approximately another 4.5, which includes not just COVID tests and treatment, but also now vaccination costs as well. And so we've submitted that request for reimbursement using any remaining CRF dollars. But at this time, we have no additional information from the GFO to report on. So that request has been made, but we don't know if it's been approved or not. We also applied for FEMA assistance. This was not something that we were expecting to get approved, but we thought there was no precedence for it. So we went ahead at the suggestion of those who are involved in this, and we submitted a request for the cost of vaccines to get reimbursed for the cost of vaccines. We received notification recently that this request was not approved. And then there was a request at the last board meeting to provide updated enrollment data. So as of July 1st, you can see the enrollment data here. You can see that most of those folks that went on to the low deductible plan and selected that low deductible plan came from the CDHP. So you see that the CDHP lost some members, significant amount of enrollment, and they went to the low deductible plan. Other than that, there's not a huge difference in the enrollment from year to year. We do expect, or I would expect that because this was not an active open enrollment, we did not require folks to select a plan, that in time you'll see that low deductible plan start getting higher enrollment, but it's going to take some time. So with that, I will stop there for any questions or comments that the board members may have.
Tom Verducci for the record. When the pandemic hit, we had to make some serious mandated reductions. I think in the neighborhood of $32 million per year. It was mandated. And what concerns me here is we have coronavirus relief funds as well as FEMA, and we're waiting for a response from the GFO, and I don't see the reason why FEMA would not request that. I know the members of the program have had to pay additional costs, and it's just quite concerning to me that we responded very quickly, and it doesn't seem like the response is coming in from the GFO, and I don't see the reason why FEMA has not approved these funds that were earmarked to absorb the cost of the vaccine. So just a concern on my part. I don't have the answers, but I do think whatever we could do to restore benefits and provide relief is going to benefit the membership of the program. And that concludes my comments there.
Thank you, Mr. Verducci. Any questions for the executive officer relative to her report?
Michelle Kelly here. I'm sorry,
Okay.
Just a quick question on the enrollment numbers for 2022. Executive Officer Rich, were you surprised at the small number of people, even though it wasn't an active open enrollment? I understand that, but I'm somewhat surprised that only 3,300 people switched into the low deductible PPO, given that people have been asking for it for 10 years. Maybe I'm exaggerating, but ever since we got rid of the low deductible plan, so many people have asked for it back. So I guess I'm somewhat surprised that it's only 3,300. Was that in line with projections? Did we have projections?
So I think we expected more. We did expect more. We had projected more. You know, it's sort of an odd time right now. You know, we had an open enrollment in the middle of a pandemic. You know, it is a lot of people maybe are not paying attention. We had a huge turnout, as you heard me report at our open enrollment meetings. I think that we've had a lot of communication go out, but you know, it's a plan that some people are, maybe they want to sit and watch and wait, and they don't want to pull the trigger just yet. They are comfortable on the CDHP and not ready to move. And then on top of that, I mean, I know that the numbers dropped for the HMO, but remember, we also dropped rates on the HMO too. So there was less of an expectation for those people to come from the HMO onto that low deductible plan. So I don't know if maybe if Stephanie Messier wants to comment on this as far as what she sees typically, you know, among her other clients, and when they, you know, when other clients do introduce a new plan, what kind of uptick do they see?
Yeah, sure. Thanks, Ms. Rich. This is Stephanie Messier for the record. I would say we had another state kind of go through almost an exact similar plan design introduction. However, they chose not to go with the flat dollar strategy from the state's contribution perspective, and they really did incentivize folks to that new low deductible plan in between their HSA and their HMO plan. So they did see, I would say, probably 3 times the amount of folks moving into it, just because the price point for the employee was about almost identical to the HSA plan. So based on the way we priced it, it is a little bit richer of a plan in terms of providing benefits. But as the employees are sitting there and looking at it from one plan to the next, right, it is more out of their pocket on a paycheck basis. And so I do think that hampered the enrollment that you saw, in addition to those other items that Ms. Rich mentioned. I would say the positive news is, because you all did move to that flat dollar contribution strategy, in terms of the projections being off, the great news is PEB is paying the same for a single employee, regardless of which plan they picked. So the fact that more people stayed in the HSA than we originally were projecting keeps your total spend the same. It's only if people started picking up spouses or picking up children that you previously didn't cover that would kind of change the projections from that perspective. But in terms of the total dollar cost, if people did or did not select the low deductible plan, it actually didn't change in terms of what we were expecting the state to pay in aggregate. Does that make sense?
Thanks, Ms. Messier. I think it does. Let me just ask, just to check my comprehension, let me ask, so when you say it doesn't change the cost, I guess because we've got such a large bulk who stayed in the CDHP, the state actually will pay less medical than we were planning, right? Because the first dollar out of pocket is borne by the participant. So that level of spend means that we should look better at the end of this fiscal year than perhaps the projections were going to show? Is that, or am I twisting things?
Stephanie Messier again for the record, and you are twisting things a little bit. So we price the plans based upon how much we expect the plans to pay, and then the differential between what the state is paying and the employee is paying is the total amount that the plan is covering based upon the plan design. So the fact that members have to pay more in their deductible on that lowest plan, the HSA, means they pay less per paycheck because we know they're paying more out of pocket. Does that make sense? So the state is picking up, let's say, $650 out of a known $800 cost on the HSA plan on average per person. And on the low deductible plan, it's $850. So the gap from what the state is paying right at $650 to the $850 gets picked up by the member on the paycheck basis. And then there's this other cost that we don't think about, which is what the person pays when they go and get services. So that's being accounted for in how they pay less per paycheck knowing they pay more when they go to get services on the HSA plan. Conversely, on the HMO plan, they pay more out of pocket on their paycheck, but when they go to the doctor, it's a much lower price point. Or when they get a prescription filled, for example, it's a lower price point. Did that help or did it hurt?
You know, that made perfect sense. I guess I wasn't sure that the difference in premium truly covered the full cost of that service. So you're saying it does, so doesn't matter. Thank you.
Okay, other questions? Okay, this is an informational item, so we can go ahead and move on to agenda item 7, our usual contract overview and any amendments or new solicitations.
Thank you, Carrie. Oh, sorry.
I was just going to say, I was going to pass it off to you.
Thank you. Carrie Eaton for the record. This is just a simple report this time. There's only one recommended item on this report. It's item 7.3.1. And PEB would like the board approval to amend the HealthScope PPO network contract to keep the out-of-state PPO network fees flat for the last year of the contract. The fees were scheduled to increase by 50 cents per out-of-state member per month, but HealthScope was able to negotiate this fee with Aetna and keep the rates flat. So with that, I am able to answer any questions.
Any questions? Okay. I'll accept a motion for approval.
Michelle Kelly here. I'll make a motion to accept the recommendation that we allow PEB we authorize staff to complete a contract amendment with HealthScope for the national PPO service.
Okay, thank you. Do I have a second?
Jennifer Krupp for
Okay.
April Can.
I'll take it from Ms. Collin. Thank you. Great. All in favor? Say aye.
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 Aye. Any opposed? Nay? Okay, motion carries unanimously. Thank you so much. Okay, moving on to agenda item 8, discussion and possible action regarding PEB's request for American Rescue Plan funding.
All right, Laura Rich for the record. So just an update, the state agency directors were provided some further direction just recently by the state treasurer's office regarding the distribution of those $2.7 billion that were awarded to Nevada through the American Rescue Plan, or ARP. So some of you may remember that last April, the state developed the Every Nevadan framework. And I have a link here on the report if you want to take a look at it, but it was intended to serve as a foundation to ensure the best use of these funds. And the document itself just lays the framework by identifying priorities and just the guiding principles of how these funds should be spent. So additionally, it provides an avenue for stakeholder engagement, and then it permits members of the public or the legislators and also executive branch agencies to submit ideas for ARP spending. The framework was then further deliberated in SB 461 right at the end of the last legislative session and was subsequently signed by the governor. So the state treasurer's office reports that in addition to ARP funds, there's also an additional 99 buckets of other funding available too. And that the staffing required really to interpret and apply the constantly changing guidance and FAQs on how this can be spent in relation to the growing volume of requests that have been coming in has gotten quite extensive. So as a result, a contract was awarded to a vendor to assist the treasurer's office in the development of this Nevada roadmap instead of a framework. Now we're looking at a roadmap to recovery, so it's more of a plan. This vendor is going to manage the requests that are coming in. They're going to determine if they're eligible for any of this money. They're also going to assist in the stakeholder engagement process. So due to the complexity and all of these different funding sources, the State Treasurer's Office has highly discouraged those that are submitting ideas from even attempting to determine whether that idea is eligible for the funding or not. Because again, it's not just ARP, there's all these other buckets as well. So instead, it's really encouraging all of us to submit any ideas that we have and allowing those with the expertise the ability to make that final determination during that vetting process. So the State Treasurer's Office and Governor's Office will begin this process by scheduling 75 days of stakeholder engagement meetings. If this hasn't started yet, it is probably starting soon. Through the course of these conversations, executive and legislative branch that are staff that are tasked with leading this effort will be gathering information and really trying to prioritize and make recommendations on how the state is going to spend this money. And so factors such as the state's ability to commit to funding ongoing costs, prioritization that has been detailed out in SB 461 is also going to be considered. And then, also stakeholder feedback and things like that, will also be taken into consideration. These stakeholder meetings, as I said, have not yet commenced, but PEB anticipates being invited to participate in any of the conversations surrounding employee benefits. So with that, we have come up with some possible recommendations to submit as part of PEB's request for federal funding opportunities. So we will need to submit our own request through the Every Nevadan Recovery Framework portal. And with the assistance of Aon, we've provided some recommendations for potential requests. This is not an all-inclusive list. This is just kind of our idea of, let's put some ideas out here and let's see what they look like. Certainly, we can discuss other ideas as well. This is just what staff has come up with. If there are other recommendations, we are happy to discuss those as part of this agenda item. Basically, our recommendations include plan design changes that either fully or partially restore plan design back to pre-pandemic levels. So, those deductibles, out-of-pocket maxes, things like that. Also, the restoration of those ancillary benefits, which is LTD and life insurance. And then there's also monthly premium credits that we can offer as well in plan year 23. So each of these requests must be submitted separately to ensure that each option can be evaluated and considered independently. If we give kind of one big package deal, it's hard to, if let's say there's a limited amount of funds that is able to be allocated towards PEB, we want to make sure that there's options to fund different requests that we've put forth here. So we've tried to package them into different options because, for example, we didn't want to give the option of decreasing the CDHP or decreasing the low deductible plan deductible. We don't want to do that because if you decrease on one plan, you've got to decrease on the other. It all intertwines. And so the way that what we tried to do here is package it into an option that incorporates everything that is not going to leave the plan at a kind of wonky levels as far as different actuarial values, where we have three plans that are the same because they all have the way that they're made up with their deductibles or their out-of-pocket maxes basically make them equal plans. We don't want equal plans. We want different plans that fit different scenarios and different needs for people. And so the way that we came up with these options is basically kind of a package deal, right? So we're lowering all deductibles, lowering all out-of-pocket maxes, things like that. So where if you're doing something to one plan, you're doing it to the other as well. And so the options here that we have are basically that we're lowering deductibles. There's a couple different options to lower deductibles, a couple different options to lower those out-of-pocket maxes. We have an option here to revert co-insurance and also those co-pays. There's the restoration of LTD and basic life, and then a $44 premium credit. The reason we stuck to $44, it's not an arbitrary number. It's just that you don't want to give more than, because this is pre-tax, you don't want to give a credit that is more than your premium. And so that is the $44 was the lowest premium. And so we took that, and then per month, it's $1.4 million. If you want to do it annually, it would be $15.3 million, taking into account that there is a 1 month premium holiday. We did price these out because as part of the submission, we do have to include an estimated cost. We also have to include a detailed explanation. And one of those explanations is, is this an ongoing cost? Is this something that, the agency is going to need to be funded to continue? The estimated cost here you'll see is highly caveated with this is a very premature estimation. We're very early on into the plan year, and it is difficult to really come up with a cost estimate, but we can do our best. And so Aon has taken the information that they do have and come up with their estimate of the cost with the information that we have today. So with that, I will stop there for questions and any discussion.
Board members, you're so quiet.
Well, yeah, Tom Verducci for the record.
Okay.
Laura, this is for Executive Officer Rich. Could you speak about, in terms of the process? I mean, I know the board does not have a decision to this decision-making power to restore all these benefits. I believe it has to go through a few layers. I mean, if we made a motion to restore all benefits to pre-pandemic levels, what would that entail? Would it have to go through GFO, IFC, and what power does the board have to do this? It seems to me that we could come up with a wish list. My wish list would be to restore all of the benefits to pre-pandemic levels, if possible. But I do believe that that does have to go through GFO, IFC, and what we put forward is more or less a wish list. And I also see the $15 million annual expense, and I believe we had reduced the budget by $32 million a year. And I just want to point out or ask a question if we're also including HSA and HRA contributions that are subsidized from the state. So that's a lot there, but I'm more concerned about the approval process, what we need to do to get things restored.
So Laura Rich, for the record, this is really just step one of the process. This is, how is the state going to divvy out the $2.7 billion? And where does PEB fit into that picture? That's a good question. I don't know. Will we get all 36 million restored, or will we only get, maybe 1.4 to change to a leaner alternative deductible option. You know, there's definitely this is what is going to be discussed in this process of, you know, stakeholder meetings and trying to, you know, come up with a statewide initiative where the funding gets prioritized. And I don't think any of us here today know where PEB lies in that prioritization. So this is really just our attempt to submit requests and to attempt to get some of that, some of these benefits restored. Now, Tom, you did mention, you know, we had our budget cut by 36 million. That's a request you can make too. You know, I don't know if that would fit the requirements, but like we've been told, it's not up to us to determine whether it meets the eligibility of, you know, getting funding. And so we could submit something saying we would like $36 million restored to our budget, and leave it at that, right? And so, but unfortunately, we do not have a say in you know, what gets chosen and what doesn't, other than through that stakeholder process.
So in reading the public comments, it seems like there's a human cry out there for some immediate relief. And going through the executive officer report, you know, we're looking for a response from the GFO on some COVID relief money. FEMA has turned us down, and I just don't see nothing to lose in putting out the recommendation to restore all benefits in addition to this list, the HSA, HRA, employer subsidy. And then as it goes through the processes, some of it will stick, some of it won't. But, you know, as I've mentioned a few times, we were quick at dropping the benefits, and I see it going very slow at restoring it. And since we're not the deciding factor that can restore all these benefits, I think we put out the suggestion to restore them all, including HSA and HRA. And what sticks is what sticks. And the legislators and the governor's finance office, I believe, is the ultimate say there, as well as perhaps the treasurer's office. So I just would like to see some movement on getting these things restored. And I do hear the voices of the employees, and I do read those public testimonies that are quite compelling, that state employees are looking for some relief, and this is the big issue. So those are my thoughts.
I do want to add that we are not limited to one option or two options or 10 options. We can submit as many as the board chooses. I would probably recommend that there's probably a sweet spot of more than one, but less than 10. So that's just my recommendation, but we are not stuck with this is the only option.
Laura, this is Betsy. A question. Is there a reason, this list looks good to me, but is there a reason why the restoration of the HSA, HRA has not been put in there, or the additional monies?
That's another option that we can throw in there, and it was discussed. It would just, so we can, like I said, you do something to one plan, you have to do something to the rest of them as well. And so if we leave everything as is on the CDHP and just raise the HSA contribution, then we'd have to do other things to the low deductible and HMO options as well, just to even those plans out and to make sure that we've got the actuarial value that is different between the plans. So Aon can definitely put together an option that includes HSA.
I just had seen that in the some of the comments. And so my guess is then that some of these other reversions back about the copays and stuff didn't go as far because the HSA then wasn't put back. I'm fine. Thank you.
So it's Michelle Kelly here. I just wanted to ask some specific questions, not about the choices here, because I agree with Mr. Verducci. Our participants are crying out for help. And Ms. Messier might be exasperated with me, but I'm going to go back to the point I made, or the questions I asked about kind of the low deductible and the impact on the plan. So just to be very specific, looking at option number 1, for example. So we've got revert the deductible to pre-pandemic, basically across all of the plans, which I totally understand. What you have to do to one plan, you want to make equal with the other plan. Where I guess I'm having trouble reconciling that is when I look at the estimated cost, it's $3.5 million. But the majority of our participants are actually in the high deductible PPO. So of that total cost, the $3.5 million, I think Executive Officer Richard shared with me maybe $2.1 million. If that was restored, maybe the majority of the money in that cost would be actually going to high deductible members. And so I guess when we're looking, so one of the principles I think I would like the board to think about, I guess, is the total cost, because to me that's the plan. So if for example, if that went ahead and $2.1 million of the cost and we got it approved from the American Rescue Plan was going to CDHP, then shouldn't we be putting a request in that makes sure that whatever happens to the low deductible PPO and the HMO is of equivalent AFP funds, so the $2.1 million? Isn't that how we maintain the actuarial integrity of the plan and make sure that all participants are treated equal? Or am I just totally, once again, it is a question, even though it's as a statement.
I think, Stephanie, are you?
Yeah, sorry, my mute button was not coming off, so I didn't want to start talking when you couldn't hear me. And you're not exasperating me, Ms. Kelly. Those are good questions. So I would say, though, when you're talking about the dollar amount being the same, it's a little bit trickier of a concept, right? Because we have to go back to the percent of the population within one plan or another is a little bit different than trying to say, when we're making plan design changes, what we did originally, because you did have a pretty large hit to your budget, right? We were really looking at cutting out $36 million, I believe, in 1 year. So when we were making those plan design changes last summer, I want to say it was a 5% actuarial value deduction across the 2 existing plans with an introduction of a new plan in between those 2 to try to offer meaningful choice to your population. So as you look to restore the benefits, I think what Ms. Rich is trying to get at is that you're not trying to restore 4% of the 5 that you took out of the CDHP, but only 3 on the HMO side. And you're never going to get to the true dollar to dollar perspective, but we're trying to, because it's a percent of a dollar and there's more people down here than there is in this plan, we're trying to universally lift them, right? Rather than picking one up and dropping another, because at some point, if you did do what Ms. Ayo mentioned and give more HSA funding back, you might get to a point where that in terms of the payroll amounts, because is it fair that the people in the low deductible plan today pay more than the HSA folks? And now if you made the HSA plan richer than that low deductible plan, the low deductible plan should then decrease accordingly. And it becomes an issue again, where now maybe their actuarial values are nearly identical. And are you really offering meaningful choice to your population? And you certainly can. I have clients that have 2 plans that are very similar in actuarial value with another richer plan. But I think the most ideal place to have plan designs is to have 3 distinct plan options. So you really are offering a choice for members, because people will access care differently based on their personal family medical situation. And I think that's a true value to PEPS participants that I think you probably want to just keep in mind as you're making these choices.
Thank you for that explanation. Yeah. So if we, for example, just put in option number 1, and it's just for discussion's sake. So you're comfortable that if we put in option 1 all on its own, that maintains the actuarial value of each of the plans? Because I agree with you about the choice, and we want to maintain the differentiation between each plan and the cost. So I'm not arguing with you. It's just more, does this number 1 all on the face of it meet those goals?
This is Stephanie Messier again for the record, and I would say not quite. So we were trying to find the best way to bring this before the board today, right? And there's not really a great option outside of trying to do live modeling, which I think we've run into with issues in the past in a public board meeting. So we're not going to make that mistake again. But just try to, I guess, give you a good idea of how much it costs, right? I probably wouldn't recommend that you just change the deductibles, right? I think it does make more sense in trying to get to that goal of maintaining a good spread on your actuarial values to look at deductibles plus the out-of-pocket maximums, for example, or some of these other choices. But we did want to give you the size range of what these different options mean. Like, I do think the second option is also a good option, because one thing to keep in mind about your HDHP plan today is that the IRS is at the $1,400 threshold. So at some point, if you go back to $1,500, you're not only giving your members whiplash, but the 15 will no longer be within the IRS regulations. Potentially, you may have to then bump it up to $1,550 or $1,600 and keep making that changes 1 year to the next within that particular plan. So potentially, picking that second option to change the deductible in between where you used to be to where you went, right at the 1,600, might help you maintain a 1,600 for a few years before you run into that IRS issue. But yeah, I would say purely we didn't look at the actuarial values for each different step to make sure that gap is maintained. It would be something I would say, as we're redesigning a plan for plan year 23, we'd want to take a look at to see if there's some additional tweaks that could be made, and how does that then affect payroll amounts and those other things. But in terms of trying to get this I'm probably going to get the acronym wrong, the funding, just picking that one option may tweak your actuarial values a little bit and not quite have the exact same gap that you have today, but at least it's moving all of the 3 plans directionally the same. Not exactly precisely as we probably would want it to be.
Okay, this is Laura Freed. I want to thank Member Kelly for those questions, because I had kind of the same thoughts. I was like, well, were each of these options put together with the goal of maintaining the actuarial value of each plan option? And when the original presentation was done, I thought, oh, yeah, they were. And now it sounds like, well, yeah, mostly. Okay, got it. So thank you for that discussion. Tangential to that is the suggestion that the lien alternatives to the deductible and out-of-pocket max, that both of those be put into the portal for consideration, or that the board choose revert deductible back or change deductible to lien or alternative, revert out-of-pocket max back or change to out-of-pocket max to lien or alternative. So in other words, are we just like, throw it in the portal, all of it, or pick one?
So this is Laura Rich. My thought on this is that should we want to focus on decreasing the deductibles, we choose the best one, right? We choose the one that reverts it to pre-pandemic levels. And then once those stakeholder meetings we're involved in those and we have those discussions, perhaps I can say, okay, well, if there's not sufficient funding for that, how about we take it down one notch and we do the lien or alternative? And so we're not bombarding with all the submissions, but you can leave the responsibility onto me to communicate that. That's an option, but we can definitely, we can submit them separately as well, just so that the options are there in writing and, and can be considered. But I think that ultimately, if that discussion comes up, that the conversation around, well, how can we tweak it a little bit is probably going to come up as well.
So it's Michelle Kelly here. So I guess when I saw this list, I am concerned about us putting in kind of just this level of detail, just because I don't think it's very structured. And so when I think about, from my perspective, is I think that the board, maybe we should think about putting together 3 different options, or have, I'm sorry, not us, but have Executive Officer Rich work with Aon to put together 3 different options, like a stretch. So you know what? I've heard Mr. Verducci say we should ask for the full 36. So as a stretch goal, what would, putting back $36 million, what would be the components for each of the plans that would equal that total? And then maybe, a step down from that, a middle ground whereby the board picks the number, because it is kind of random, right? But the board picks either the number or the items to go into that midstream that maintains the actuarial integrity of each, and then an entry level in case they decide there's absolutely no money and we are not a priority. I think that for me, I would like us to maybe submit, as I say, 2 or 3 options that are kind of bundled options. So not individual options, but of a dollar value that is determined by Executive Officer Rich and Aon together. That's my thought. And it could be made up of all of these things. But so I heard, I think Executive Officer Rich say the deductible would go with the OOP. And so that makes sense to me. And so maybe we do that, on the, but we list each bubble is for each plan so that it's very clear what we're asking for, but we're not also putting in for like 10 or 12 different submissions. Thank you.
Thank you. Other board members, do you have any reaction to what you see before you in the staff report?
Tom Verducci, go ahead.
Oh, I was just going to say that if we work too many other options, will we not get them submitted in time that we need to, if this needs to be voted on in a public meeting? That's the question I have.
So I think that if the board is willing to, the board can provide some general direction, and then Aon and staff can go back and put together a plan and submit it. There's no drop dead deadline at this, at this time, but I think the sooner we get this in, the better, because, these stakeholder meetings are going to start, and we definitely want to be a part of this process. So I think just given general direction by the board in terms of a board consensus on what it wants to include, Aon and staff can go back and put together something, and I'm happy to share it with staff or with the board at a future board meeting. I can do that as well. But this way it gives us the opportunity to at least submit it.
Yeah, Betsy, because I'm concerned that the longer it takes to occur, more months go by while people are living under the other option.
Just a point of clarification though, none of this is going to take effect in this fiscal year or this plan year, right?
Correct.
Yeah,
that's correct.
That would, these are only options because, of course, we have set the rates and everything for 22. So, this would be for FY23 only.
So just a question here, Tom Verducci. During the pandemic, did we go into the catastrophic rainy day reserve fund? Is that something, I mean, that was definitely a catastrophe last year. And I believe that fund set up for catastrophes is still in place. I mean, I just can't remember. Did we go into the rainy day fund?
So Stephanie can correct me if I'm wrong, but yes, we can dip into that category. However, you've got to backfill it. And so if you use that money, then eventually it needs to get refilled. And so those rates, everything, you know, we're back at square one, right? It's not a bucket of money that we can use to restore funds. It's really not an option.
Yeah. So to be a little more clear here, during 2020, did we indeed have to go into the rainy day fund for our budget, or was it at that time left in place?
And this is Stephanie Messier for the record, and Carrie Eaton, I'm going to also throw it to you, but I believe in Plan Year 21, you tapped into it in a way because you reduced it from the 60 days on hand to 45, and that was used because of a budgetary number that you needed to give up. And so you did actually tap into it, and I believe cut it by 20 to 25%, but I could be wrong, or maybe Chair Freed knows.
This is Laura Freed. I don't remember the number. I'd have to go back into my old board packet, but we did ring a one-time savings. You're right, Ms. Messier, by reducing the number of days of catastrophic reserve, and then we did we did a one-time savings from the incurred but not reported reserve. So the short answer to your question, Mr. Verducci, is yes.
So we did go into the reserves, because where I'm going at with this, I mean, I really would like to see these benefits restored to the maximum extent that we can. And we went through a catastrophe last year. We survived it. And I just really think we're shortchanging state employees. I read through those testimonies on the public comments, and I just think something needs to be done. I'd like to suggest a full restoration, and I know that we don't have the power to do so, but I don't think we have anything to lose asking for it, because there are layers of state government, GFO, IFC that would go through and have to be the final source. And we were quick to reduce those benefits, not to be repeating myself, but I think we're in a position right now to be asking for maximum restoration, including HSA, HRA, and everything back to where it was. I know that's an all-encompassing statement, and maybe I'm being a little bold asking for that, but I just think we're in a position where the board that needs to speak up and ask for it.
So this is Laura Rich. We can certainly ask for anything. Something the board needs to keep in mind, and something that will definitely be taken into consideration and factored in when these decisions are made by those that make the decisions, is that this is for next fiscal year. So if let's say that we are granted $36 million to restore funds for fiscal year 23. At that point, we can do this all for fiscal year 23, but what happens in 24 and 25 when those funds are gone, right? So there's a consideration of, can we keep this up? And can we continue to provide these benefits to members? And is it fair, or maybe it is fair to members to provide them, 1 year of these excellent benefits because they're covered by by the ARP funds, but then the subsequent biennium, we're back to where we are today, right? And so that's something that needs to be considered, because there's a perception that our budgets are not going to look much different moving forward in the next biennium. So there's likely going to be, and I'm not saying this because I've received direction or any kind of guidance or anything like that, but nothing formal, but there's an idea that, or an expectation that our budgets are not going to look much different moving forward as they did this biennium.
Tom Verducci, just as a follow-up question, how is our cash differential account, used to be known as excess reserves? Did I hear in the neighborhood of 35 million? Is that where we're at right now?
It's a projected 35 million, yes. I will say that the utilization has been very, very volatile. We've been up, we've been down. I mean, it's been very volatile in comparison to previous years. And so I'm hoping that there's some stability in the next coming months so that we can collectively, the staff can make recommendations as to how to move forward with that excess. But at the same time, it's any expenditure of those for benefits will have to go through IFC, and that will need to get IFC approval. So there's definitely there's steps to using those funds.
Hey, yeah, very good. Because from what I'm reading, it doesn't look like the state employees have a lot of excess reserves. So whatever we could project to the decision makers, present to them, I think would be appropriate. And I know there's probably a good process as opposed to just throwing a full restoration out. I like what you have listed here. Other than HSA and HRA should be included as well. And I'll leave it up to other input from other members. I don't know exactly how the motion, I don't think we're quite there yet, but I mean, if I was to make a motion, mine would be for full restoration and have it go before GFI and IFC to see what is affordable. And we've got to get these deductibles back down to affordable levels, out of pocket, back to where they're at, and long-term care, life insurance restored. And I think now's the time to do it. And that's my compassionate comments.
Thank you, Mr. Verducci. I appreciate that. Other board members, do you want to weigh in on this? Do you have any feelings or comments? Anything on this that's not on the staff report list that you would suggest adding?
Chair Freed, this is Tim.
Okay.
I wanted to mimic Mr. Verducci's position that we did have to make cuts, and now we're at a point where we can restore those benefits. And I am all for fully restoring back to the deductibles out-of-pocket maximum and the addition of the HRA, HSA contributions on top of that.
Just to, this is Laura Freed, sorry for the record. Just to be clear, move the HSA and HRA contributions by the state back to what they were in plan year 20. Is that what you guys mean?
Tim Lindley here. I would say plan year 21, it was 700 participant and 200 dependent with up to 3 dependents max, if I remember correctly.
Okay.
As though, pretty much put everything back as though there was no pandemic.
Okay. So 700 for the primary participant, 200 per child to up to 3. Okay.
Yes.
Okay. How does everybody feel about the premium credit? I'm curious because this is not something we've ever discussed in terms of benefit design. And I don't know. I'm not sure where the idea came from and whether I like that equally or better than restoration of HSA and HRA funding.
This is Betsy, if you're asking about that.
Yeah.
I think the reverting the deductible, the out-of-pocket max, the benefits similar to where they were are probably more important than a premium credit. The other thing that's not on here is, again, decreasing the premiums to where they were, and that's probably what the premium credit's trying to do. I'm guessing that that's where that came from, but again, it's just a guess. But I think overall, employees, and I'm not all the employees, but from what we've read in public comment, they would like to see the benefits back to where they were as much as possible.
Yeah. Okay. Ms. Curran?
I just wanted to chime in and say I agree with what Betsy's saying as far as the approach to premium credits. I think based on what we're hearing from the public, we need to consider restoring some of what we've cut rather than pushing through the credit, the $44 credit.
Okay, thank you.
Tim Lindley here. I would mimic April's comments.
Yeah, I thank you guys for that. I appreciate that. I think Betsy may be right here that it's sort of an attempt to lower premiums, effectively lower premiums, but again, that leads to rate shock when the money runs out. You know, whereas HSA and HRA is sort of, I mean, it maybe functions in the same way in the end, but it's not you know, if they flatten premiums for plan year 23 and then they go back up in say 25 or something, then everybody's unhappy. So that's kind of why I agree with what you've all said. Okay.
Can I jump in with a quick clarification on the HSA and HRA contribution?
You bet.
So there were some comments about going back to the 700 base plus the dependents and all that. I just want to remind the board that there was a policy change, and I can't remember which board meeting it was. It may have been in, oh gosh, I can't remember now, but we changed the policy to employee only. So we are not getting into the weeds of trying to contribute for the two dependents, because then it gets, again, we're playing a guessing game. How many dependents are people going to have, and budgeting becomes a nightmare. And so I think that was why we had changed the policy to only dependent, or I'm sorry, to employee only, primary only. And so in that case, I just want to clarify that should we do something like this, it would be based on the HSA funding for a primary only, in terms of, yeah, there's a bucket of money, we'll figure out how we can divvy it out for the employees only, but not including that dependent factor.
Tim Lindley here. Thank you very much, Ms. Rich, for clarifying.
And if I could just chime in real briefly, this is Stephanie Messier for the record. I do want to clarify, if you restore benefits back to what they were, you're actually making the out-of-pocket maximum higher for those folks on the EPO and the HMO. It used to be, I believe, up at 7,000 something, and we brought it all down to be the same level regardless of which plan a member picked, so that they had, you know, the same protection. So if you restore it back to those levels, you would actually be increasing someone's out-of-pocket spend on the HMO and EPO plans. I just want you to recognize that it's a detriment to the employees, that particular change. I didn't want everybody to think that that was a positive for them.
Michelle Kelly here. So I guess in line with what everyone is saying and what our participants are asking for, could we then, would the board be on board with us just giving direction to Executive Officer Rich to reinstate the dollar amount and to come up with a plan to do that, that perhaps, you know, protects, that keeps the maximum out of pockets where they are, you know, equal for everybody, which is the direction the board went in, but then adds back the $36 million to each plan, or its share of each plan equally, to get us back to where we were had the pandemic not happened, I guess. So then we would rely on them actually putting together the detail of the plan, but the direction is to reinstate the dollar value of the cuts.
this is Betsy, and I would be okay with that. But I do like what you said, Michelle, to begin with, that we're asking for everything, but it would be good to give them some options so they don't just jump over us if the ask for everything is too much.
Tom Verducci, I just think if we just ask for a dollar amount, this can be a very difficult argument to make. I think if we just ask for full restoration of benefits as to where they were pre-pandemic, with the adjustment that Aon and Stephanie just went over with the out-of-pocket maximum, to adjust it to the level that Stephanie just went over. And I think at that point, I mean, we've asked for it. We have nothing to lose, and I think restoring benefits is what the employees are asking for. And if the funds are there, excess reserve, we have a lot of pandemic relief funds out there. I just think it's the least that we could ask for. We might not get it all, but we can ask for it.
It's Michelle Kelly here. I would be supportive of what Betsy said, and perhaps giving direction to staff to build a second plan. So offer, obviously we want full restoration, but if that's not, for me, if we don't give a second option, then we're actually giving the Treasury and the governor's financial, the budget people, the right to design the plan. And, the NRS says that the board is meant to be designing the plan. And so, I would prefer to give them one or two options in case the full 36 isn't available, but 20 is available, for example. That's just my thought.
No, this is Laura Freed. I agree with those sentiments, Member Kelly. I think you hit the nail on the head. It's not really GFO's job to do plan design. So if we're going to ask for federal money to effect plan design changes, then we need to decide what those ought to be, and then leave the sort of, the equity, in the insurance of equity among different plan options to the staff and the actuary.
So this is Laura Rich. I have an idea that I'd like to propose. And Stephanie, if I'm off base here, please jump in. So what if the submission really is a range in cost? So it could go anywhere from X million to X million, depending on what is available and where, what PEB is might receive. If we have some direction from the board as to what the board wants to prioritize. Do we want to prioritize deductibles? Do we want to prioritize out-of-pocket maxes? Do we want to prioritize the copays and things like that? So if we have a kind of a guidance, then at that point, when we're having these stakeholder meetings and we have some idea of what what they're willing to allocate, or what we can, or what basically the conversation is, then at that point we can say, okay, well, if 36 million is not an option and only 6 is, then we'll design a plan design option that meets the $6 million mark with the board's goals in mind. Right. And so if you prioritize what's most important, are deductibles important, or out-of-pocket maxes, things like that. So I think that staff with Aon can build options once we know more.
This is Betsy, and I think I can go with something along that idea. And I do think deductibles are very important, and then out-of-pocket maxes, because when people get really sick, the out-of-pocket max makes a big difference.
This is Laura Freed. I completely agree. If you would like my prioritization, deductibles and out-of-pocket maxes are it.
This is Jennifer Krupp. I'd like to agree with those sentiments, that deductibles and then out-of-pocket max. And then the other thing that I did want to touch on that I would be concerned about is continuity of benefit levels moving into future plan years. I know Director Rich had mentioned that, but I do think that continuity of benefits and maintaining those benefit levels are extremely important for state employees. And so I'd really like for us to focus intentionally on being able to sustain these benefits and not increase benefits one year and then have to decrease them another. That's a lot for families to manage.
Tom Verducci, I would concur that the reducing the deductibles and the out-of-pocket maximums are probably the two most important. Getting rid of the co-insurance, I see it as important as well. Restoration of long-term disability, restoring the basic life, I do see that as important. And the premium credit, I see that as a temporary item. I don't see quite the importance there. But I do think that two big ones are the deductibles and the out-of-pocket maximums being reduced.
It's Michelle here, and I just wanted to, thinking about Ms. Krupp's comment, which I agree with 100%. I did want to, I guess I'm a little confused by something Executive Officer Rich said, where everybody's expectation is budgets will be flat going into the next biennium. And I don't work in the budget department, but what I do read is the newspapers. And, I live in the South. So the newspapers are telling us that the gambling revenue, which the state relies on for the majority of its revenue, is back. And in fact, it's higher than it's ever been. And so as we think about designing benefit packages, I just want to, just urge a little caution in being too conservative because of this perceived flat budget. Because if our participants are reading the same newspapers that I'm reading, in the next fiscal year, I fully expect that our budget should be fully reinstalled. Now, I know that that's a Pollyanna view, but budgeting is complicated. But when all you see is the newspapers and we're seeing the revenue come back into the state, barring this new outbreak of pandemic, but even after it dies down, people are eager to spend and people are spending. And so the money is coming into the state. That's what we're reading. And so if we then as a board, start being super conservative in kind of going, well, we're worried about a flat budget next year, I think our participants don't understand why we're taking that position if they're reading and seeing what I'm seeing. So I just wanted to put that out there because, that flat budget it's puzzling, right? I mean, anyway.
And Ms. Kelly, I just want to say, again, I haven't received any formal anything saying that we're going to get flat budgets, but given the fact that legislation was passed where, a lot of, and this is what I've heard, is that any new monies coming into the state is going to be diverted first and foremost to education. And so unless there's a whole lot more money that comes into the state than is expected, it's not expected that agencies are going to get funded at higher levels. Now, that's not, it could be different by the time that budget building starts and we get actual guidance from GFO. But at this point, that's kind of what I'm under the assumption of. And that's why I'm a little hesitant to say, look, our picture is going to look a lot rosier next biennium, because it might not. And so, I don't want to bank on money that we don't have. And so I'm working under the expectation of this is what we've got. If we get more, then great, but we have to live under the reality of this is probably what we're going to be expecting.
This is Laura Freed. The other thing to note is that gaming percentage fee is just under 20% of the state general fund. Sales and use tax is about 30% of the state general fund. So sales and use tax is the biggest revenue source, and I can't tell you where that's going. But I mean, Member Kelly is right. I mean, gaming win is up and continues to be up, but we'll see if that holds in the pandemic. And then we've got modified business tax and insurance premium tax as the other significant sources of general fund revenue. Okay, I'm hearing quiet. So we've talked ourselves to, I think, a consensus about the prioritizations for requests for art money being deductibles and out-of-pocket max. And I heard also some support for restoration of LTD and basic life. Are we feeling ready to make a motion to that effect, or?
Tom Verducci, just a comment. I'd also suggest some restoration of the HSA and HRA employer subsidy contributions that were cut back.
Okay. Can you be more specific?
I believe member Tim Lindley had read back the exact dollar amounts, what they were pre-pandemic level, $700. Tim, would you be willing to read back what you read back, what the pre-pandemic HRA and HSA contributions were?
Mr. Verducci, Tim here for the record. The HSA contribution for the participant was $700. I did mention dependents. However, policy is that we don't do HSA contributions for dependents. The HRA contribution was $13 per month per year of service, and that did not change.
So in terms of the subsidy that's coming from the state, I believe there was a reduction that we did put in place post-pandemic. Does that ring any bells?
Mr. Verducci, this is Laura Freed. If you mean the HRA reduction, we did, and then the legislature used general fund to restore it.
Okay, all right.
Actually, they used excess reserves to restore.
Oh, I'm sorry. I take that back. They used general fund for the other restoration. My bad.
Well, thank you. I knew Tim would have the answer there as the auditor. Some of these numbers are quite complex, and there's a lot to them to have memorized. But I'm all for the full restoration of benefits. I know just throwing it all out there is probably not going to stick in a motion here. It needs to be more specific, and I do want to emphasize that I see the most important being reverting back to deductibles, the out-of-pocket maximums, followed by the reverting the co-insurance from 20% down to 0, restoring LTD, restoring basic life. Those are the priorities that I see.
So is that a motion?
You're free, that would be a motion.
Okay. So let me restate if I heard it right. Revert deductible back to, you mean the pre-pandemic $3,000, decrease low deductible plan deductible to $300 and $600 for family. And for out-of-pocket max, back to pre-pandemic of $3,900 and $7,800 per family on the CDHP, $7,150 and $14,300 on the EPO and HMO, and decrease low deductible plan out-of-pocket max to $4,000 and $8,000 for family. So that handles deductibles and out-of-pocket max. Do I have it so far?
Yes, Tom Verducci here. I would like to incorporate the comments that Aon had made about further reduction with the out-of-pocket maximum, taking into consideration the introduction of the new low deductible plan. So everyone is at the true pre-pandemic levels, and we're not in a position of increasing anybody's out-of-pocket maximum.
Okay, well, bear in mind you can broaden your motion and leave it to staff and the actuary. The motion can be revert deductibles and out-of-pocket max back to pre-pandemic levels, accounting for the addition of the low deductible plan and doing their level best to make sure that, as Ms. Messier said earlier, everybody's risen up to the same level. Does that sound like something you could do?
Yes, Tom Verducci, that sounds very acceptable.
Okay. Great. All right. So, having disposed of deductibles and out-of-pocket max, now you want to suggest reverting coinsurance from 20% to 0, except for the low deductible plan, going from 20%, 50% to 10%, 40%. Do I have that right?
Yes, that is
okay.
Correct.
All right. And then you had restore LTD and basic life.
To pre-pandemic levels.
Okay, right. To pre-pandemic levels. Okay. And that's it, right? Or did I have, or did you want to add HSA for primaries to pre-pandemic levels?
Yes.
Okay. All right. I think we got there. All right. So do I have, go ahead.
And just for discussion, if there's any input from any of the other board members on anything that could have been left out that are important to them as they see that would be beneficial to the program, I think right now would be a good time to add that on to the motion. If I'm leaving anything out.
This is Betsy, and I'm wondering if it would be acceptable to you, Tom, to add to that motion to give PEB the ability that if the money isn't provided to restore all those things that you said, that the deductibles and the out-of-pocket max would be prioritized, and then copays and HSAs or whatever order, so that they have an ability to, if we don't get that max, work it down a little bit. Unless the way you listed was the priority.
Yes, so I think the wording could be simplified there, where we could say that the two most absolute important things are reducing the deductibles and the out-of-pocket maximums to pre-pandemic levels. So rather than making this too complicated, I think the chair had some very good wording that was already in place there. And I am willing to alter this motion if there's anything I'm leaving out that's important to other members.
Okay. Well, I'm not hearing anybody. This is Laura Freed. I'm not hearing anybody speak up. So it seems like we should go with, all right, accepting Betsy's idea that if we don't have, if PEB isn't going to get the money to do all the things on its add back wish list, the most important thing is deductibles and out-of-pocket max. So once again, revert deductibles and out-of-pocket max to pre-pandemic levels to the extent that it doesn't lead to, unintended weird outcomes. In other words, letting the staff and the actuary make sure that it's equitable across all plan options and everybody benefits more or less equally. Then we have coinsurance. Then we have LTD. Then we have basic life. Then we have HSA payment of $700 to primary.
Yes.
That's okay. That's what I got.
So moved.
Okay. All right.
Chair Freed, Tim Lindley here. I like the way you broke it down, and I will second that.
Okay, great. It's been moved and seconded. Does everybody understand what's in the motion, and does anybody have questions about that? Okay, cool.
Michelle Kelly here.
Oh.
Just a quick question for Executive Officer Rich. I just want to check that gives her the flexibility she was looking for in her discussions, with the stakeholder, as part of the stakeholder group, et cetera.
I think so. Yes, it provides guiding principles, right? So I think that helps us as discussions are had to prioritize the board's intent and goals in this. So I think this is good.
So, Tom Verducci, do we make that addition to the motion to give Executive Officer Rich the flexibility to make those changes? How does that need to be worded?
As long as the seconder is good with that, that is permissible.
Second motion guy here, permissible. The seconder.
That sounds great. Okay, guys. Robert's Rules of Order for the win. With that, there's a motion on the floor, and I will call the question. All those in favor signify by saying aye.
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 Any opposed, say no. Okay, sounds like the motion carried unanimously. Thank you very much for your deliberation on this one, everybody. I appreciate it. And I'm sure that the executive officer will be in touch if she has any clarification needs for us. So with that, we are on agenda item 9, our second public comment period. So I will call once again upon Broadcast Services to ask for public comment.
Thank you so much, Chair Freed. We are currently on public comment. If you have joined the call and would like to provide public comment, please press the raise hand button in your Zoom window or press *9 on your telephone to take your place in the queue. Caller with the last 3 digits, 832, please proceed with your public comment.
Thank you very much. And for the record, my name is Terry Laird, spelled Terrilaird. I'm the Executive Director for the Retired Public Employees of Nevada, RPEN. Just want to say it's good to hear PEB staff and the board are continuing with the process of seeking pandemic-related federal funding to help restore some of the benefits cut by the Nevada State Legislature due to the mandate from Governor Sisolak caused by the 2020 pandemic. PEB does need to take care of its participants and those future retirees hired before 2011 who will actually receive retiree health care, because it needs to be pointed out that the Nevada Legislature in 2011 did vote to no longer offer retiree health care contributions for state workers hired on or after January 1st, 2012, which is important to note following the discussion under item 4.4 about Opeb and the elimination of funds in PEB's RBIF account when it was empty during the last recession. While we are all extremely concerned about the cuts from the latest legislative session, it's also important to realize that many of the current state workforce may not even receive retirement health care benefits. RPEN would hope someday that that group can be considered looking toward the future. And in addition, in 2011, when Medicare retirees were moved to the Medicare exchange, PEB's retiree costs were also dramatically altered at that time as well. But again, we're happy to hear what's going on with those the funding going forward, and we look for some hope from the state level. Thanks again for a second opportunity to speak.
Caller with the last 3 digits, 499. You are unmuted. Please proceed with your comments.
Madam Chair, members of the committee, Carter Bundy with AFSCME again, CARTERBUNDY. We want to thank you for the discussion. I thought that was a really thoughtful discussion. And Member Verducci, I know, had mentioned several times about the coinsurance for the high premium plan. And a couple times that got left out of the discussion, but I think Director Rich mentioned it in the last go round. So I think that's in there as well. So we really appreciate your paying attention to this issue and to the needs of the employees. As far as the one-time budget money versus long-term, I just want to make a couple of quick points. The first is we don't know what budgets will look like down the road, as Member Kelly mentioned. And at the very least, I think we shouldn't be negotiating with ourselves. If we can get this for the next few years, and remember, the ARP money is available through FY25, through the middle of FY25 at least. Look, that's 3 years where we can get it, and then we find ourselves in the 2025 legislative session fighting to keep what we have. And obviously, we all understand that budgets are finite. But at the very least, I think we should try to do as much as we can now, and we don't want the sticker shock in 2025 or 2026. But 3 years is a long time, and I think that becomes part of the budget, and then we're fighting for it the way every other group that's advocating for their people are fighting for their piece. So I would agree very much with Member Kelly's point that we shouldn't be too conservative about worrying about flat budgets and recurring items after the ARP. It will be what it is, but this money is available now, and if it isn't used to help restore healthcare, it'll get used for something else. So I would just encourage everyone to press ahead with this as much as we can and hopefully restore all of it now, and we'll continue to be right by your side to keep it that way in future sessions. Thank you so much for your time.
Caller with the last 3 digits, 111. Please proceed.
Thank you very much. My name is Janelle Woodward, JANELLWOODWARD, and I'm a state employee and AFSCME member. I think that most employees would probably hail Mr. Verducci and Ms. Kelly for their support of restoring benefits. Especially the parts that move the cost from the plans to the employees. There was much great discussion today throughout the whole meeting that was very interesting, but the discussion regarding raising the benefits and then having to turn around the next year and cut them again, I think it is a little premature. And with all due respect, PEB has cut healthcare benefits every 2 years. And this is an opportunity to say, we don't know what it's going to look like next year or the year after that or the year after that, but let's do what we can do right now and restore as much as we can to the employees and prioritize state employees in the one time that we actually can do that and really make a huge difference. Just imagine the praise you all would get if this was to be able to go through on this. So I would really support what Mr. Verducci and Ms. Kelly said about let's go forward and ask, because the least you can do is ask and then see what happens. But thank you so much for your great discussion today. We appreciate that. Thank you.
Thank you, caller. We are currently on public comment. If you have recently joined the call and would like to speak in public comment, please press the raise hand button in your Zoom window or press *9 on your phone to take your place in the queue. Chair Freed, there are no additional participants who wish to speak in public comment at this time.
Okay, thank you very much. I appreciate Broadcast helping us with the meeting today. And that leads us to adjournment. It is 1:23 p.m. and the meeting is adjourned. Thank you very much, board members, for all your participation today.